morning.
Good morning, Your Honour. Today we have three expert witnesses giving evidence by way of conclave. Can I just introduce to Your Honour the three experts in the court?
Certainly.
Seated in the witness box on the left is Professor Tom Kotsimbos, surname spelled Kotsimbos. To his right is Professor Craig French. Both have travelled from Victoria today to give evidence in the court. On the screen, we have Professor Susan Curl. Her surname is spelled Kurrle. Professors Kotsimbos and French will be affirming. Professor Curl will take an oath.
Thank you.
And I might just say some introductory remarks in terms of the structure of the conclave for those present. What I intend to do is to ask some general questions to begin with. Then I will move into the 19 individual cases. In respect of each of the 19 individuals that are the subject of inquests, there will be a question asked about the cause of death and then three further questions asked. Each expert will have an opportunity to provide their opinion about each of the matters that's raised in the conclave, and then I'll turn at the end of each question, effectively, there'll be an opportunity for the experts to comment on each other's views that they've just heard evidence given about. After the 19 individuals have been addressed in the expert evidence, we will then move out into broader themes again, implications, consequences, matters of that kind. That's the proposed structure for the examination in chief.
Thank you. Thank you for that outline. Yes.
Silence, please. Do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say, I do.
I do. Thank you, Professor. Please have a seat.
Thank you. Do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say, I do.
I do. Thank you, Professor. Please have a seat.
Professor Curl as well.
Professor Curl?
Yes.
Do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, please say, I do.
I do.
Thank you, Professor.
Thank you. Can I begin by asking each of you some questions about your areas of specialisation and expertise? If I could start with Professor Kotsimbos. You are a specialist physician in respiratory and infectious disease.
Correct.
You've practiced in those areas for in excess of 25 years, is that right? You're a staff specialist, respiratory physician at the Alfred Hospital in Melbourne.
Correct.
And the Alfred Hospital has been designated a COVID-19 tertiary hospital expert centre in the state of Victoria. Is there anything further, Professor, you'd like to add about your qualifications or expertise? Professor French, you are a specialist anaesthetist and intensive care physician, is that correct?
Correct.
You have practiced in those fields since 1998.
Correct.
You're the Director of Intensive Care at Western Health in Melbourne, and you have treated over 60 critically ill patients with COVID during the Victorian outbreak in 2020.
Yes, we've now treated over 200.
Right. And that's up to date. Is there anything further you'd like to add about your qualifications or expertise? Thank you. Professor Curl, you are a geriatrician.
Yes.
And you've practiced in that field for in the order of 35 years, is that right?
That's correct.
You're a senior staff specialist at the Hornsby Ku-ring-gai Hospital. Is that right?
Yes, correct.
And you were directly involved in the care of residents from Dorothy Henderson Lodge during the outbreak in 2020?
That's not quite correct. I was indirectly involved, other than for one resident who did come to Hornsby Hospital following the outbreak.
What was the nature of that indirect involvement?
The patient had dementia and there were some issues with her wandering, and I was involved in managing those and then getting her back to Dorothy Henderson.
Is there anything further that you'd like to add in terms of your qualifications and experience?
Just that I have been involved with a geriatric outreach service that goes from hospital to residential care for the past 20 years. So I am in and out of residential aged care facilities, nursing homes, on a fairly regular basis.
Thank you very much, Professor. Each of you should understand that your detailed reports are in evidence in these inquests. So those reports have been received and what's written there will be carefully considered. Hence, there's no need to replicate everything that's in your report. You can use this opportunity to now expand on areas of significance. In preparing your reports, is it the case that each of you had access to the medical records that are in existence for each of the 19 residents who passed away? And I'll just go in the order: Professor Contimbos?
Correct.
Professor French, Professor Curl?
Yes.
And can I ask you each now in turn whether you also considered other material in the brief of evidence? Professor Contimbos?
I think there wasn't anything else specific that I can remember.
Other expert reports, for example?
Oh, sorry, of course. The other expert reports. There were things that were important that I didn't consider, that I wasn't provided. And that was the other patients that were positive at Newmarch House, COVID positive, and also the staff members and how that all fitted into the whole epidemic of what occurred there.
Right. You're indicating that you were not provided with that information.
With that, yes.
Right. And I think
certainly the other expert reports I did consider. You've
drawn attention in your written report to those pieces of information that you weren't provided with.
I think they have particular relevance.
Right. Professor French?
I had access to the extracts of the medical records that were provided to me. Similar to Professor Kotsimbos, I did not have knowledge of other residents at Newmarch House who contracted COVID-19 and their management and outcomes. I also was not provided with any operational details of the infection control practices or hospital in the home or virtual aged care service, and they are outside my areas of expertise, which I acknowledge. And the expert reports were provided to me, have been provided to me, but they were provided to me after my opinion was written.
Right, but you've had the chance to review those,
read them. Yes,
and obviously that will be incorporated into your evidence today to the extent that they impact on your opinions.
Correct.
Professor Curl?
I also had access to the medical records of the 19 residents who died, and also statements from James Branley, Andrew Kincaid, Grant Millard, and following my report being submitted, I recently had access to reports of Dr. McIntyre, Dr. Bennett, Dr. Ibrahim, and my two colleagues who are with us here today.
Thank you. The first general issue that I want to take the conclave to is the manner in which COVID was being treated in the period April to June of 2020. And can we start with a general observation about the different forms of treatment that were being provided, and then I might move in to particular modes of treatment such as supportive care, more aggressive forms of treatment, etc. So starting with you, Professor Consimbos.
So that period, April to May, was still in the period in Australia where we really didn't have a lot of COVID. COVID started very late in December in China, and then we had our first case sometime late in January, and I've detailed that in my report. The situation was it was a very new virus. There was a lot not known about it, and all the initial focus was on preventing spread. So as much as we could tell from how the epidemic was spreading, we instituted, and the government instituted, and the healthcare services instituted policies to stop the spread. That was the key focus. And that had there was a whole raft of measures associated with that. If someone got sick, then the care was predominantly supportive, and it was supportive in two senses. One was the virus was very much a respiratory infection, but it was an unusual respiratory infection because although it caused respiratory problems, it also caused other problems in the rest of the body. And for instance, one of the extra problems very early on was clots. And this meant that supportive care had to take into account those sort of problems. And particularly the clots meant that, the respiratory problems meant that the main supportive care was providing oxygen, and the clots and people being sick, the main supportive care was meant that fluid and electrolyte balance and sometimes anticoagulation was provided. The next aspect of supportive care was any other underlying condition had to be dealt with in the setting of this now significant stress. And so the patient had to be managed with those two things in mind. And the supportive care had to be in an area where that could be done. The sicker you were, in terms of comorbidities, the harder it was. And in fact, the case fatality rate in patients that had significant comorbidities and were older, and there were specific comorbidities that were associated with higher risk, particularly high blood pressure and diabetes and cardiovascular problems, that had to be managed specifically. I think that would cover it for me.
All right. Professor French?
I agree with what Professor Consimbos said. Just to highlight that there really, in terms of, there was no effective antiviral therapies available then. Some people were trialling the use of remdesivir at the time, but it was not known to be effective and certainly wasn't in routine practice. There was emerging evidence from overseas about the role of steroids. However, again, that wasn't in routine practice at that time. So really the principal treatments were directed towards symptom relief.
Yes. Professor Cole?
I would agree totally with my colleagues. I would simply add that certainly the WHO in March 2020 said that for frail older people, bringing in the comorbidities that have already been mentioned, they should be managed within a comprehensive geriatric medicine framework. So looking at all the comorbidities and managing them all along with the active infection. So that would be the only thing I'd add.
A comprehensive geriatric framework, is that something that can only be provided in a hospital, or can that be provided by way of a VAX type service in a residential aged care facility?
It can be provided that way, and indeed happens that way with current geriatric outreach services. It is a little more difficult when you do not physically assess the patient. So a virtual VAX, the virtual aged care service, would not be able to provide that comprehensive geriatric medical assessment with the same degree of accuracy as would occur in a face-to-face assessment.
Can I, just while we're concentrating on supportive care, and I haven't moved yet to escalation to other forms of care, just while we're concentrating on supportive care, can I just, is it the case, and I'll just list a number of forms of symptom management or treatment, that supportive care involved the following: oxygen support, physiological or electrolyte monitoring and correction, pain relief, prone nursing, the provision of fluids, and antibiotic treatment for secondary infection. So I've put a list there. I might start this time with Professor Curl. Are they the sorts of treatments that would be involved in respect of supportive care, or do you disagree with some of those in the list?
No, I would agree with them all. I think supportive care is used in this sense as everything but invasive care, such as ventilation, intubation. The prone nursing is the one thing that I think was attempted in residential care on a couple of occasions, but was not managed successfully, because you do need much more nursing care than was available to do that. The others on your list, I would definitely agree with.
Can you just tell us what exactly is prone nursing?
Prone nursing is lying someone on their front. And I would defer to my two colleagues in terms of why that is so important. But certainly it was recommended, but very, very difficult to do. And I think we need to note that with the 19 residents, most of them had documented cognitive impairment, so probably would not understand an explanation of why they were expected to lie on their front for long periods of time, because that is not how most older people would lie in bed.
Professor Consimbos, that list of treatments or approaches to supportive care?
I'd agree with Professor Curl. I'd add a few extra things. I think there's a structure to supportive care with each of those systems. So in terms of the respiratory support, there's low flow oxygen, there's higher flow oxygen, there's oxygen through nasal prongs, there's oxygen through a mask. So there's an increasing and escalating delivery of oxygen. And that's related to the need for oxygen when the lungs are impaired. There's not enough oxygen getting into the lungs and then into the body.
And each of those gradations of oxygen therapy would fall within supportive care?
But there's an escalation.
Yes.
Right at the end, when the lungs are very significantly impaired, and particularly with patients that you can do it with, that will follow instructions, proning helps, because it helps ventilate the lungs that aren't very inflamed and involved with the inflammatory process. But that's right at the end. It's a severe... it's at the severe aspect of what's going on in the lungs. So it's not far away from needing to put tubes in and so on. So I just want to give you that feel for that.
Thank you.
I think fluid support is always important, and particularly in patients, and I tried to draw this out in my report, particularly in patients that are on high blood pressure medications, may not be eating and so on, and then get sick, because not having an adequate fluid intake can have its own circulatory problem and then compound the hypoxia, the low oxygen level. So those two things. And then the other aspect of supportive care, particularly in the early part of the epidemic, was this unusual thing, and there's a lot of pathobiological reasons for it. There was a lot of clot going on. There were a lot of vessels were clotting as a way of trying to control the infection, which is not the case now, for instance. And it was particularly the case with the early ancestral strain of the COVID virus.
Why did clotting emerge as a problem? What was the physiological reason for that?
Well, we don't know exactly, but we think that it was very much observed in the severe cases. There was a lot of clotting going on in the severe cases in ICU that actually did pass away. The post-mortem studies showed a lot of clot everywhere, but also in the lungs. And that added to the hypoxia, because oxygen getting into the blood isn't just a function of getting through the lung. It's got to get through the blood vessels in the lung. And so when they're clotted, we have an extra problem, and that's why it's significant. So dealing with the clot problem was important as well in the more severe cases. There's a lot of theories why. One of the reasons proposed is it's a very ancient mechanism. When we don't have prior immunity to a new virus, one of the ways we can control it is we clot it off. You know, it's a very old mechanism. And that's one postulate.
All right. Professor French, anything to add?
I agree with what my colleagues. The other thing I would say about prior ventilation is it started in the critically ill population. That's where the evidence was initially provided. And I'd make the comment, in April 2020, proning of patients that weren't ventilated probably was, in my experience, not a common practice. It's something that's probably evolved since then.
In very specific groups, because as Professor Curl mentioned, it's not an easy thing to do. You have to have a very helpful patient.
Medication. Or the clotting. Just one particular question about clotting. Is that treated by way of anticoagulants? And is there evidence that the use of that type of treatment can have an impact on the falls risk, the risk of falls in elderly patients?
Yes. So very specifically, your answer is yes. So there has to be a risk-benefit assessment of whether we use the drug or not, the anticoagulant or not. So let's say, to give you the two, if you like, bookends, in an older patient with a little bit mild respiratory infection, a little bit of hypoxia, and the risk of falls, you wouldn't, because the risk outweigh the benefits. In a younger patient who's facing ICU and significantly hypoxic, and there's the possibility of clots being involved, you would. And then there's a gradation in between.
Professors Curl and French, is there anything either of you would wish to add to that answer?
Just in terms of anticoagulant therapy for COVID-19, again, that was the subject of a lot of research which commenced at or around that time, and it subsequently became apparent that in certain populations, anticoagulation, that is in thinning the blood, did reduce clots and did improve outcome. But at the time, in April 2020, that was not known.
Right. And it is important, as we go through the evidence, that we keep that time frame in mind. Particularly April and May of 2020 are the key periods of interest in these inquests. And just before we move on, there was a reference, Professor Katsimbos, to mild hypoxia. Can you just provide a specific description of what mild hypoxia is in terms of, for example, percentage of lung function or something along those lines?
Right. So the way we measure hypoxia, that's the easiest way to measure hypoxia, is to put what's called an oxygen saturation meter as a probe on a vascular bed, so the nail or something. And that will read how much of the circulating hemoglobin is saturated with oxygen. And generally that can be 100%, it can be 90%, 95%, it can be 90%. At 90%, that saturation correlates with a pressure of oxygen in the blood that's reasonably good. So, and below that, it becomes quite low. So it becomes very hypoxic. Anything above 90% is still hypoxia, but the higher you get, the milder it is. The lower to 90, 92%, it starts to get more severe. But below 90, 92%, it becomes severe, as I said. So there's a gradation, but it's not a direct line. It's a sigmoid curve. And the critical point is between 90 and 92%.
Professor French, you're nodding there.
Yeah, I completely agree with the sigmoid curve.
Right. Okay. And Professor Curl, is there anything you'd want to add there?
No.
Now, before we move off supportive care, can I just ask about two other issues? First of all, monitoring of vital signs, observations. In a cohort such as this, elderly COVID-positive patients in an aged care facility, what sort of level of monitoring of vital signs would each of you regard as an appropriate standard? Would you aspire to? And I'm talking in terms of the frequency of the monitoring, clearly.
I'm happy to start.
Yes.
I think I'm not a nursing home expert in terms of what happens, and I think Professor Curl will add a lot to this. But
right. Well, perhaps then we'll start with Professor Curl.
Certainly. If we're talking just residents' normal day-to-day, vital signs are not normally measured unless there is an indication for it. However, coming into COVID, clearly there were reasons to measure, particularly, as has already been outlined, the oxygen saturation in the blood, and importantly, pulse and blood pressure, and also temperature. Now, there is a machine that basically does all these things, and it is wheeled from resident to resident, hopefully with some disinfecting in between. A lot depends on who is carrying out the measurements, remembering that staffing in residential aged care on the whole does not have very much healthcare training, and often their familiarity with these machines is somewhat restricted. And I certainly noticed that in some of the readings where you were given readings such as for blood pressure, systolic 110 to 160. Well, yes, but where is it? And they're basically meaningless. So it is really important that vital sign observation is done by someone that knows how to do it and documents it correctly. It is difficult because of issues around infection control, staff numbers, staff skill, even sometimes the cooperation of the resident themselves. So doing vital signs is not nearly as easy in a residential aged care facility as it might be, say, in a hospital setting where people are trained, the patients are usually by their beds and they are happy to accept having these things done to them.
There's evidence has been obtained in this inquest that COVID-19 is an illness that can result in rapid deterioration of the patient, particularly with elderly patients. First of all, is there any controversy about that, or is that correct? Against that background, what sort of frequency of monitoring should be occurring with this type of patient cohort? And again, Professor Curl, can I just start with you? Do you have a view about that?
And I would probably defer to my colleagues. I would certainly want those observations to be done, I would say 4 times a day. They would be done more often, I suspect, in hospital. But that allows you to see how someone is when they've woken up, perhaps during the day, late in the afternoon, when perhaps they will deteriorate, and then in the later evening, at least 4, 5, 6 hours apart. That does spread it out. However, if someone does deteriorate and it's obvious that's happened, then you would again do you check vital signs again. But it's very difficult. It means people have to be looking at their residents. And of course, in this case, many of them were confined, well, all of them were confined to their rooms, and staff did not always go in to check.
Professor French.
I guess I'm going to speak from a hospital experience. I have no experience in residential aged care. The frequency of observations depends upon the patient's severity of illness and also the treatment goals for that individual patient. So for the majority of persons that with COVID in an acute care hospital, they would be having observations, from my expectation, at least 4 hourly, and then more frequently should their clinical condition worsen, and then ultimately when their frequency of observation gets to a level of somewhere, often maybe needing observations 2 hourly or hourly, that is almost a sign then that they need to go to a higher acuity of environment, such as an intensive care unit.
Thank you. You add anything, Professor Consimbos?
I completely agree with my colleagues, but I would add an extra framework. I think the whole point of observing and measuring is you have a model. Why are you doing this, and what are you going to do about it? And that is the critical thing here. If the reason you're doing it is to catch something that may a signal of worsening, then you have a set of. If you don't expect it to be worsening quickly, then a couple of times a day is fine. If you do see worsening and you're going to do things about it, you have to escalate the measurement. And so really it all comes down to why you're doing it. If it's just to catch the signal in case it happens, then a couple of times a day is fine. But if someone is sick and you're expecting deterioration, then it has to be more frequent, and your intensity and your level of analysis all is framed by what you're going to do about it. If no matter what you find, you're not going to do something about it, then that changes everything.
The other aspect of supportive care that I wanted to ask about before we move to more aggressive forms of treatment concerns the use of medications such as dexamethasone, which I understand is a steroid. Was that being used in April 2020 as part of the treatment regime? If not, when was it introduced and to what effect? Professor French.
It was not widely used in April 2020.
Not widely, is what you just said.
It was being studied, principally overseas in Europe at the time. The results of those trials became available later in 2020, released on a preprint publication, and they actually had a profound effect on practice, certainly from an intensive care perspective, where the proportion of patients receiving steroids went from very low levels up to very, very high levels. And the results of steroids certainly in those most severely ill did appear to improve survival. The results of the use of steroids in the less severely ill were not as convincing.
Professor Katsimbos, anything you'd wish to add there?
Two things. One is in the less ill, it was actually the situation was worse.
Yeah.
So you really, the dexamethasone, the high-dose dexamethasone was beneficial in someone who had severe lung problems as a way, if you like, of dampening down an over-exuberant immunoinflammatory response.
Yes.
If you were milder and you gave it, it looked like the signal was worse. You did worse because you still needed an immune system to control the virus. So that's an important distinction. And I agree it only became available later. In some of the patients, they did have dexamethasone or steroids, but for other reasons. Sometimes we give it for asthma. It's a general purpose anti-inflammatory when we think inflammation is playing a big role in the disease process. But it wasn't widely being used as a COVID treatment at that time.
Professor Cole, anything
Nothing
further?
to add.
Thank you. Lastly, fluids. Are fluids important as part of supportive therapy? If so, why are they important? Professor Katsimbos, perhaps.
I sort of touched on this a bit earlier.
Yes.
I think they are important. They're important probably on at least three levels. One is if we need fluids, we have fluid losses, and if we're sick, then not having enough fluid becomes a problem for our circulation and in terms of our physiology. That's the first thing. In a COVID setting, those losses are greater, other things are happening, there's hypoxia, it compounds the problem. And the last thing is that being adequately hydrated is a much more comfortable way to be than not being adequately hydrated. And particularly when you're not in a position to hydrate yourself. And particularly if you're taking medications, maybe for other reasons that may make you lose extra fluids. For instance, diuretics for high blood pressure or heart problems.
Professor Curl, we're particularly interested in a geriatric perspective here. How important is fluid delivery in your area of medicine?
I agree. It's extremely important to maintain homeostasis, to keep people's blood pressure at an appropriate level. If you are unwell, you may not want to drink as much, and we know in older people their desire for fluids is decreased. They don't sense thirst in the same way. So it's really important, even in very well older people, to make sure they maintain their fluid intake of around 1.5 litres a day. Assuming they're not on medication, that might make them lose more than that. And it is quite difficult because it means staff need to be encouraging fluid intake. So when someone is sick, it is even more important for the reasons already outlined by Professor Kotsimbos. It is just so important so that people can continue to function. And I think particularly to keep their blood pressure up so that if they do stand up, they don't immediately fall over. Which happened obviously on a number of occasions in various residents at Newmarch House. So maintaining that is really important, and it's part of supportive care. There is a real push against using intravenous fluids, so that is a cannula going into a vein and then the fluid is given that way. But I would note that the use of subcutaneous fluids is probably much more common than most people realise in residential care, and we use normal saline. So that's a slightly salty solution. That's the same osmolality as blood. And what you do is you simply put a simple, small, what we call a butterfly needle in under the skin. And if someone's dehydrated, you can run in quite a lot of fluid that way, but you don't affect the heart. You don't overload the heart or the lungs by doing that. And I think the use of subcutaneous fluids was mentioned, but I'm not sure they were actually available at Newmarch House at the time. I would note that they are regularly used in outbreaks of gastroenteritis to keep people in residential care rather than them coming into hospital, because fluid intake is just so important.
Just two follow-up questions there, Professor Cole. One, is this correct? Subcutaneous fluid delivery, less invasive than intravenous fluid delivery, but more effective than manually giving fluids? And second question, if fluids are given, should that be charted in the medical records?
I would say yes to both.
Thank you. Professor French, is there anything you wish to add on the subject of fluids? Professor Kotsimbos.
I would like to add one other aspect to this. If we are losing fluids and we're not keeping up, and there are medications that make us lose fluids, then a good medical assessment would be to stop those medications or alter how we're doing that. So there's a dynamic going on here that also involves constant assessment and adjustment.
Thank you. Can I move now to more aggressive forms of treatment beyond supportive care? And I might turn to Professor French first, because this plays to your particular area of expertise. Professor French, can you outline what the more aggressive forms of treatment are and what's involved in particular in terms of transfer to an ICU?
So if admission to an ICU is deemed to be clinically indicated, we are able to apply advanced oxygen therapies in the intensive care unit. And they involve the use of intubation and institution of mandatory ventilation. So that's the placement of a plastic tube down into someone's windpipe and going onto a breathing machine. That's called invasive mechanical ventilation. There's also non-invasive ventilation, which requires the use of a tight-fitting face mask and the application of positive pressure through that mask and oxygen to help the patient breathe. Those systems are both what we call closed systems, so the amount of inspired oxygen that can be delivered is very high. You can deliver up to 100% oxygen via those means, because when a person breathes in, all the gas that they're breathing in is coming through the machine. They're not entraining any room air. Other modes of oxygenation that we used in intensive care, and were also used in some hospital wards as well during the pandemic, included the use of high-flow nasal prongs, and that involved the use of specialised nasal prongs that were quite wide in nature, and the administration of up to 60 litres a minute of fresh gas flow through that. All these devices usually require a bulk gas supply, so they are not able to be supplied from standard cylinders for a prolonged period of time. That's why hospitals have very large bulk gas storage. And they also usually run from plumbed outlets in the wall, so they're not run from standard cylinders.
Right.
Whereas the lower flow oxygen therapies may be using between up to 6 to 8 litres a minute, can be run regularly from a bottle of oxygen, shall we say, but everything else does require bulk gas supply.
Is it the case, I'm just going to ask a follow-up question, is it the case that intubation and ventilation is a particularly burdensome form of treatment for the patient? And secondly, is it likely to be the case that with an elderly patient cohort, such as the one that we're dealing with here, that they would be less likely to be candidates for that type of active intervention?
Certainly, every patient needs to be considered individually, but as a general rule, those persons that are frail and have significant comorbidities, intubation and mechanical ventilation is unlikely to be effective in restoring their health. And as you said, because it's an invasive treatment and inherently burdensome because of that, if a treatment is unlikely to be effective and is also burdensome, it is usually not medically recommended.
Right. In your experience in the ICU department, were there patients, say, older than 75 years of age, receiving that type of intervention?
Yes, there were. We did treat older persons in the intensive care unit with COVID. Unfortunately, as a group, the outcome for them, particularly those that were invasively ventilated, was not good and with a very high mortality. I think it's also important to note that at the time, and that those persons that were being admitted to intensive care that were older were in general not frail and had minimal or if any comorbidities. So we're looking at a population of older persons who are well, frequently independent and at home, with minimal comorbidities, and their outcome was very poor. And that also then really supports the practice that in a frail person with frequent comorbidities, the institution of such treatments really needs to be carefully evaluated.
You've provided in your report some statistics about survival rates, effectively.
Yes.
Were there any stats coming through in April of 2020?
No. The reports that I provided were reports related to the collection of data in Australia through the Sprint-SARI data, and also some data that we were getting from the United Kingdom at the time as well. But in terms of published reports in peer-reviewed journals, there were none at that time that I'm aware of. But in general, irrespective of the diagnosis, whether it's COVID-19 or another illness, a person who is frail with frequent comorbidities is much less likely to benefit and have their health restored by invasive treatments than someone who is not frail and has few comorbidities.
Professor Kotsimbos, is there anything you'd wish to add to that?
I agree with everything Professor French has said. I would say that early on it was a running assessment. You know, the people that were getting COVID and getting into hospital were our first cohort, and so the people that they were very sick. We had this idea that this illness was very, very severe, and many people were dying, and that was particularly true of the group in hospital that went to ICU. So the mortality rates initially were of the order of 50% or so, but it was a running spreadsheet, if you like, because what it depended on was diagnosing the cases. So right at the start, the cases that were being diagnosed were the most severe. In other words, you had to go to hospital. But as diagnostic testing broadened out and more of the community got tested, it became very clear there was also a mild end. So if you had mild COVID, the case fatality was very low. If you had COVID that got you into a hospital, it was a bit higher. If you had COVID that got you into ICU, the fatality rate was higher and still very significant, even without comorbidities. And so I think that's a very important point. And the other strong point I want to make is treating supportively in this setting is all predicated on the underlying pathology getting better on its own. We're just supporting. So if your underlying issues are significant with a whole lot of other problems, that's much less likely to happen.
Just before I go to Professor Curl, clearly it's not the case that the only type of treatment that could be offered in a hospital is ICU level ventilation. Right. It's also possible to provide supportive care in a hospital.
I think it's not only possible, that's the main thing we do. And,
right.
And the other aspect of this, taking it right back to the start, it's about having the processes and the staff and the education and the resources to limit infection spread.
Thank you. Professor Curl, can I ask you to respond to what your two colleagues have said, but in particular, can I ask you just to reflect on one part of Professor French's answer, which was that it was the case that elderly people came into ICU units and that just because you're elderly doesn't mean that you're frail. If I could just ask you to expand on the relationship between age and frailty in a patient.
Certainly. Frailty is a state of, I guess, where your physical function deteriorates and you don't respond to stresses on the body in the same way as you do if you are not frail. Now, the most common risk factor for frailty is age, but they are definitely not synonymous. And you've only got to watch a 100-year-old, running a 400-metre race to realise there are some exceptions to age and frailty. But it is really important that we look at the frailty situation of a person probably more than their age. However, that being said, as Professor French noted, even in the non-frail older people, their death rate is higher, and age certainly is an issue there. And I think it's important to note that those people that get into ICU are really, really unwell. There are a lot of people who in hospital who don't get into ICU and who go home. And I think Professor Katsimbos noted that supportive therapy, which is basically what it was at that stage in hospital, was actually quite effective for a large number of older people. They went home, I think particularly of the 92-year-old lady from Dorothy Henderson, who was very mobile and drove many of our staff mad with her walking around wanting to go home. She was quite a good 92-year-old. She did not need intensive care, but she benefited significantly from the supportive therapy that she received, and she recovered. So it's, will the patient respond? And I think it was pretty clear, and it still is, that the older you are, the lower your chances are of coming out of ICU, because basically it means you are very, very sick when you go in.
Professor Katsimbos, you raised your hand. Was there something you wanted to add?
Quick reflection that it's not in the supportive care on the ward isn't just low oxygen and in ICU, it's all the high-end stuff.
Yes.
In fact, the big change for us in managing COVID at that time was introducing high-flow oxygen, which was very well tolerated by the patients in a ward setting to manage the patient so they didn't go to an ICU until hopefully a lot of them got better, some didn't. So it was the hospital situation had that other extra capacity of offering a higher level of support, a significantly higher level of supportive care, but not in an ICU setting. I just wanted to make that clear.
I take it that in the wards that you're talking about, it was a situation where there would have been single rooms as well as shared rooms, is that right?
Single rooms. We, as much as possible, we use single rooms.
Single rooms. Just before I move off aggressive treatment ICU departments, Professor French, if one were to advise either the patient or, if they lack capacity, their next of kin at this time about being admitted into an ICU, How would that? How would you advise them about prospects? Would you be using percentages in terms of survival rates, or is there another way that you'd have that type of conversation?
In those conversations, we usually, what we'll do is we'll discuss with individual patients and try and ascertain what their values and preferences are. Occasionally, the patient may have an advanced care directive in place, but that's still relatively uncommon. We ascertain their values and preferences, and then we will have a conversation regarding the intensive care treatments that are available, how effective they may be there. And it's not just effective the effectiveness is not just whether the patient will live or die. It can actually be what is the likelihood of the patient's health being restored to a sufficient level that it is acceptable to or consistent with the person's preferences and values as well. And they're individual conversations that we have. It's becoming more common for those conversations to actually be occurring in the community, which is good. So when persons do deteriorate, we have an understanding of what they would need. I guess ultimately the decision about how effective a medical treatment is going to be is really determined by the medical staff who administer that treatment. But what we have to ensure is that the treatment we are providing is, as I said, consistent with the person's wishes and values.
Would that conversation involve a discussion of percentile chance of recovery?
Not usually. I think it's very difficult to sort of use those sorts of individual percentages. In my experience, I often will talk about what is the most likely outcome and the next most likely outcome, and provide that information to the families and or the person involved, and help them and work with them to come to an agreement about what is the best treatment plan for them in the event of deterioration. These conversations can be obviously difficult for medical practitioners to have and for patients and their families to participate in. And you've also got to recall that when a person is acutely unwell, then there's a lot of anxiety and distress at that time amongst the person and their family. They know they're unwell. And so they're quite challenging conversations to have at that time.
And just to finish on this topic, is there a risk that assigning some percentile chance of recovery could be misleading?
Potentially, because we really don't know. They're basically estimates on a population. So while I can say that if I have 100 people, X will survive and X will die with a particular condition, I can't tell an individual whether they are one of the people that's going to live or die. So in that percentages, I do not tend to use.
All right, thank you. Anything that Professor Coyle or Professor Katsimbos you want to add before I move?
I think Professor French has explained it very well. All I would add is that you've got to read how that information is getting across in terms of, because the whole idea here is to give the information to the person so they can make an informed decision. So there has to be some sort of read that they're understanding.
The previous set of questions is focused on the forms of treatment that were in place in terms of supportive care, more aggressive forms of treatment. Can I now step back one level and ask about different modalities of treatment? And what I've got in mind are different platforms like hospital in the home, a virtual aged care service, and hospital treatment, those different modalities of treatment. Can I start with you, Professor Coyle, just to comment on those different forms of treatment?
I'll start with hospital in the home, which I've certainly been familiar with for probably 25 years. And classically, that is providing a level of care into a person's home, the level of care that might be provided in hospital, but it is for very specific conditions or illnesses that require particularly, say, intravenous antibiotics or in some cases anticoagulants. It's something that is used in the community relatively successfully, and it means that there are nursing staff and in some cases medical staff visiting the person at home and providing support at home. My comment would be it is much, much more difficult to do in an environment such as residential care because you've got multiple patients as they become in one environment. And we can discuss some of the limitations of that later. But virtual aged care service is...
Just before you move to virtual aged care, while you're commenting on hospital in the home, can I ask these two questions? One, and they're related, is that a system that is designed for patients that are medically stable? And secondly, is it a treatment modality that is appropriate where there is a risk of rapid deterioration? They're the two questions.
Yeah, the first is that certainly having a patient that is medically stable is quite important. Not only medically stable, actually able to look after themselves, to be able to do things like make a cup of tea or go to the toilet themselves. So there's a degree of independence and a degree of cognitive awareness, I guess, that are very important in that situation. If someone's going to deteriorate rapidly, they would be coming into hospital no matter where they lived, because you need to be able to monitor them regularly in that situation. And I certainly, as someone that uses hospital in the home, I would certainly not be recommending the use of it for anyone who is likely to deteriorate. They need to be in hospital.
You're then going to go on to discuss VACS, Virtual Aged Care Service, that type of platform.
This, I think, is very much telehealth. We do a form of virtual aged care service where I work, where we provide assistance, particularly to general practitioners in the care of their patients and also to residential care facilities in the care of their patient. But it's very much a telehealth service. But I would add, we do an awful lot of non-virtual aged care as part of that, because you can't necessarily make a good assessment, as I said earlier, to do a comprehensive geriatric assessment, which means looking at the person as a whole, their cognition, their bladder, their bowels, their mobility, plus all their other illnesses and their medication and their family situation. You really need to do that. Either you do it face-to-face or you have a nurse or a nurse practitioner that works with you that does it face-to-face. So virtual services always run the risk of missing things. And of course, you have to have an older person or someone at the home that is capable of managing technology and managing the devices on which you are doing that assessment. That being said, we do some virtual aged care, but not in the same way and not to a large number of residents in a facility. If we did it, it would be to one resident in a facility. So it's a difficult area, but COVID has pushed us in that area. And in April and May, as you reminded us of 2020, we're at a very early stage of understanding all these things.
What's your view about the suitability of a hospital in the home / virtual aged care service approach, some sort of hybrid between the two, in the context of residential aged care facility, significant number of COVID positive patients?
I don't think it was the optimal approach to caring for older people. It's very difficult if you've got an infectious disease, and we know this particularly with influenza. We would tend to bring residents from an aged care facility into hospital, and that would have been my approach in this situation as well, as it was in Dorothy Henderson Lodge with their COVID outbreak, which occurred just before the Newmarch House one. The hospital in the home does not work with infectious diseases, particularly in people who are cognitively impaired and in large groups like that. And when you don't have staff that are healthcare trained to look after these people who, by definition, are quite sick.
Professor Consimbos, can I ask you for your comments? You've heard those issues, hospital in the home, virtual aged care service. What would you wish to say about that?
Everything that's been said. I would add 2 or 3 extra things, perhaps.
Yes.
The first is there's a clear trade-off. The being in the hospital, has a lot of resource, but that's where you get the maximum amount of care. In the hospital, in the home, in the VAC setup, you stay where you are. There's a certain comfort to that, but there's nowhere near the quality of care, just as a general statement. The hospital in the home program, Professor Curl, I completely agree, it's very specific. The way we use it, whenever someone's sick, it's never to start therapy. We bring them in, make sure they're stable. Then we have a management plan. So it's a very clear approach to what's going to be happening at home. If something changes, they come back into hospital, just to give you the setup. It works because it balances the need for a specific treatment that is going to be prolonged, but can be managed in the person's home or outside of the hospital. As soon as there's variation around that, it becomes too difficult to manage.
And what you seem to have indicated there, Professor, is that a critical part of that, or a predicate, is that there's some sort of assessment that takes place right at the beginning to ensure that they're an appropriate candidate on an individual basis for that type of...
And ongoing. And I think the extra thing I would like to add is that the HIF and the VAX setup essentially relies on the information that's being gathered in the nursing home setup or wherever the person is. So that's an important consideration, because you don't have all the information perhaps coming back.
And do you agree with what Professor Curl has said? That is, that in performing this initial assessment, there are, if not advantages, it's required that there be a face-to-face contact at that point to perform that process.
I think so, but I think Professor Curl also said that in an infectious disease spreading environment,
yes,
with a whole lot of other uncertainties, it's not only initially, it's ongoing, and so therefore it's not likely to be a scenario that's going to end well.
Professor French, is there anything you wish to add?
I have nothing to add to the comments from my colleagues.
Thank you. While we're still on different modalities of treatment, I'm just coming to the end of this topic. I want to ask a more general question about the different reasons for sending someone to hospital. And here, what I have in mind is, does one only go to hospital to be cured of or treated for a condition, or there are other reasons why someone might be hospitalised? Professor Kinsimbos, do you want to start?
The main reason to go into hospital is because the hospital is going to provide a level of care that's going to make a difference to you. And so what's that difference? The difference, and this is where a lot of advanced care plans, I think, are difficult, because often the discussion is along the lines, I don't want to have a whole lot of extra treatments unless something's reversible. Well, how do you know whether it's going to be reversible unless you're in that situation? Because so many things will depend on what's happening at that moment, and that makes it very difficult. So the reason we send people to hospital, and we saw it for some of the patients in the nursing home at Newmarch, was because we think there's a reversible factor at play that we can help with.
Professor Curl, reasons for going to hospital?
Absolutely agree. It's the level of care. We're not necessarily talking cure. If we were talking cure for everyone that went to hospital, we'd be abject failures, I'm afraid. It's the level of care, and is it appropriate for that person to go to hospital, because the level of care they receive there will be what they need. And we do need to take heed of advanced care directives around that. But as Professor Katsimbos says, none of those advanced care directives were written necessarily to explain every possibility. And you need to have someone in hospital to show that, or to assess, and then to know that you can provide the treatment that will support them to get better. And if not, to support them to die well.
When you speak of the level of care that can be provided, does that include comfort care? Is that a reason for going to hospital, to receive a higher level of comfort?
Look, in my work in geriatric outreach services, we do on occasions have to bring people into hospital because there is no palliative care support, there is not adequate nursing care, and you cannot provide that comfort care. Comfort care usually involves medications. They're usually S8 medications. This requires a registered nurse and an enrolled nurse in New South Wales. I think you call them List 1 nurses in Victoria. You have to have a level of nursing that is able then to be able to dispense these medications. So quite often it simply can't be done in a residential aged care facility, and those people will come into hospital. It is not ideal, but certainly during COVID, I think that did happen. And I would hope that for those people that died in hospital with COVID, that we were able to provide very adequate, supportive and palliative care.
Professor French?
Yeah, I agree with what my colleagues have said. As a general principle, a person should be managed in an environment that has the necessary resources and infrastructure to meet their clinical needs, and their clinical needs by any medical treatments that were required, but also comfort care and end-of-life care if that's indicated as well.
Before we come to the residents who passed away, one last general area. Each of you comes from different fields of medicine, different disciplines of medicine, and it appears to be the case from the reports, for example, that each different discipline brings with it its own perspective about the issues that these inquests need to contend with. Could each of you speak to the focus of your area of expertise and discipline and what it brings to this discussion? Professor French, could I start with you?
Yes, well, as an intensive care specialist, I have limited involvement or knowledge of the aged care sector and the provision of some of the in-reach services that were provided. But what I can provide is information about what types of treatment would be provided in an intensive care unit, should they be medically appropriate and indicated and consistent with the person's wishes and values, and also in terms of having seen, unfortunately, many persons die of COVID. I was asked, and I've tried to provide opinion as to the likely contribution of COVID to a person's death.
Thank you. Professor Katsimbos?
And I suppose it adds to one of my previous answers. I think the value that I would bring to the discussion is essentially the understanding that a respiratory illness is more than a respiratory illness. There's many levels to the respiratory problem that needs to be considered, but also that right at the end, when there's severe deterioration in a lung problem, there may not be a lot to do then, but there's a lot of pathways that may have been taken to get to that stage, and better consideration of those pathways may have had a significantly different outcome, if not because of the final outcome, but also in terms of comfort and dignity and that sort of thing, in terms of how that trajectory was taken. And then I think my interest and involvement and specialty training in infectious disease, there's a focus on getting it right at the start, because no matter how difficult the end is and how tricky that middle part is, preventing the infection, even if it only precipitated the problem rather than causing the whole problem, could have still had a major impact on one person's pathway.
Right. Thank you. And Professor Curl?
As a geriatrician, I guess I focus on the older person as a whole person, and looking particularly at all their comorbidities. And certainly they're extensive in this group of 19 residents, which is to be expected for people living in a residential aged care facility. So I guess I would bring the effect of those other comorbidities, the frailty in particular, and the cognitive impairment, and how that impacted on the person's progress. But I would like to add that just listening to the three of us talk and coming into hospital would have much better care, because they have access to all the different areas of expertise.
Can I just stop you there? We just lost you for 1 second in that last part of the answer. Could you just pick it up from where you said listening to the three of you? Can you go back to that point? Sorry
Certainly,
about that.
sorry. Yeah, listening to the three of us made me realise how a team approach to care with the different areas of expertise is so important, particularly for an older person. And coming into hospital would allow that that involvement of the different areas of care to ensure that the person had absolutely optimal care.
Is it correct to assume that the team approach that you're talking about, if it's going to work effectively, there needs to be effective lines of communication between the different treating specialists?
Absolutely, yes.
I'm going to now turn to the individual cases. Now, first of all, there are 19 individual cases to consider. This is not a memory test, so of course you should have your notes in front of you, your records, whatever you feel that you need to refer to answer the questions. What I'm intending to do is as follows. I'm going to ask, in respect of each individual, the first question necessarily separated out will be this: what was the likely cause of death, including any contributing factors? I'm going to ask that question because that is a particular issue that His Honour needs to make findings about. Then what I will do is effectively pose three questions in respect of each individual, and there are as follows: whether there were significant comorbidities, and if there were, how they affected care for the patient and the impact on the treatment of the COVID infection. So that's focusing on comorbidities and the way it impacted on care and treatment. The next question will be issues that you have identified in the care received by the patient during the outbreak, particularly any concerns that you hold about the management and treatment of individual patients. So that's focusing on the level of care that was actually provided and any issues that you think require comment. The final question in respect of each individual will be whether, if different action had been taken, it may have affected the outcome in respect of these individuals. So can we turn first of all to, and we're going to go through chronologically in terms of when particular residents passed away, and the first resident to pass away was Mr. Raymond Jennings, Ray Jennings as he preferred to be known. Can I ask each of you, first of all, about cause of death, including any contributing factors? Professor Consimbos?
So COVID-19 related lower respiratory tract infection, and the contributing factor was his underlying ischemic heart disease.
Thank you. Professor French?
I agree.
Okay. Professor Curl?
Yes, I'd agree. He was very frail, but I think the COVID-19 infection did appear to be the main cause. He also had Parkinson's disease, along with his frailty and his ischemic heart disease. And so all of them together would have meant he could not fight off an infection.
There's some additional information that's been provided there about a possible contribution being made by Parkinson's disease.
It's included in my report. I agree.
You agree with that as well, Professor French, Professor
Would have
Consimbos?
contributed, but I focused on the key things I thought.
Right. I missed the first part of your answer.
It may have contributed because it does play into blood pressure problems and other things, but so yes, may have contributed.
May have contributed. Thank you. All right. Turning now to those remaining questions. I'm not going to ask them separately because I don't think we'll be able to get through 19. So it's an opportunity for you to deal with these issues jointly, comorbidities, issues concerning level of care and whether different action may have affected outcome. Professor Consimbos.
So in terms of the major causes of contribution to death, I focused on the two things. There were a lot of extra things in Mr. Ray Jennings' comorbidity list that probably did play a role. That he had chronic lung disease. He was a smoker. He used Ventolin, nebulized Ventolin, which in itself, if you use it in an infectious disease setting, has a risk of spreading aerosols. So that's just something to throw out there. He was one of the early people diagnosed in that first screening wave, so it's unlikely that he could have been prevented. Infection could have been prevented for him because there was already spread happening and he was picked up very early. He was given oxygen by nasal prongs and there was no note that he was particularly desaturating or dyspneic. So I don't think there was anything extra that could have been done for Ray. I don't think there was really any possibility of him not being infected given when it was picked up. I don't think there was anything extra in terms of the oxygen support. His death was quite sudden. So I do think there really wasn't another outcome that I can envisage happening.
Okay. Professor Cole?
I'd agree with that. I don't think I've got anything to add to that. No.
Professor French?
I have nothing to add.
Thank you. Your Honour, I'm in Your Honour's hands, we all are, in terms of timing. It's 11:30 now.
Yes.
That will give you an idea of the sort of time that's going to be involved in each of the individuals. And then I've got some follow-up questions after that. So we've got quite a bit of territory to cover. I think that should be safely assumed. It's a matter for Your Honour when and if we take breaks.
Yes, all right. Well, we might take the morning tea break now, given the point that we've reached, and perhaps we'll come back at 12 o'clock. All right.
Thank you.
Professors, we're going to break for morning tea now, and we'll resume your collective evidence at 12 o'clock. Thank you. I'll adjourn until then.
Please all stand. Coroner's Court is temporarily adjourned.
Professors, can I now ask you about Ronald Farrell? And once again, starting with the first question about cause of death and any contributing factors. Professor Curl, perhaps, if you want to start.
Yes, certainly COVID he certainly had significant symptoms of COVID-19. He also had significant underlying lung disease, which would put him at very high risk of dying from a lung infection. And he probably had delirium prior to his death because he had a number of falls, and that would fit with the increasing infection that he was experiencing.
Professor Consimbos?
So I agree, COVID-19 lower respiratory tract infection and significant contribution from his chronic obstructive lung disease, emphysema.
And I had the same cause of death.
Thank you.
The same contributing factors.
Just before we move on, I just want to go back to Ray Jennings for one moment. The family want it to be clarified that Ray was a smoker, but stopped at the age of 30, 63 years before he passed away. Does that impact in any significant way on the opinions that have been expressed in respect of Mr. Jennings?
Well, I still stand by the COVID-19 infection and the ischemic heart disease because of the suddenness of the death.
Yes.
I do note that chronic obstructive lung disease was noted as a comorbidity. It was hard to say how significant that was, given that he was an ex-smoker, so I didn't make a lot of it.
Okay, thank you. Professor French?
I had the likely cause of death as well as COVID-19, lower respiratory tract infection, and the contributing factors being his extensive cardiovascular disease, his frailty, and his Parkinson's disease.
Right. And Professor Cole?
Yeah, I have nothing to add to what I said before.
Thank you. So coming back to Mr. Farrell, excuse me. Was that to, I think Professor Curl had given evidence, Professor Katsimbos has given evidence, Professor French, did I ask you about cause of death in relation to Mr. Farrell?
You may have. It was COVID-19, lower respiratory tract infection, pneumonia, with his underlying severe lung disease being a major contributing factor.
Right, thank you. Now, did I not ask someone about cause of death?
You got all three.
I got all three. I asked Cole first. Sorry about that. Now, can we just move out into those three other issues, comorbidities and their impact, adequacy of the care and treatment provided, and whether some different type of action would have affected outcome. Professor Katsimbos.
So I listed chronic obstructive lung disease as a significant contributor to death, so that was a significant comorbidity and it did impact, I believe. The use of oxygen in this setting is particularly relevant because it's not just the function of treating the infection involving the lungs, it's also treating the underlying lung problem. I did note that his use of oxygen was difficult, the effectiveness of the use of his oxygen was difficult to assess. He kept on removing his mask and so on. That was noted in the notes. I also noted that he nebulizing Ventolin was used, so that has particular implications for him in terms of the need for bronchodilation, but also in terms of aerosol spreading to anyone that's in the room, staff as well, if appropriate infection control precautions were taken. I also note that there was a possibility that there may have been a secondary bacterial infection because of his underlying lung disease, so empirical antibiotics to cover that would not have been unreasonable.
Were they given here?
No. Well, no, I did say not clear. I just couldn't find evidence that they were given.
Right. You'd expect that type of evidence to be recorded if antibiotics were given?
Although I found the notes generally difficult to follow, and I wouldn't be surprised if there were some gaps. The other thing I would say is his infection. He was diagnosed as COVID positive very early in that first wave of testing on the 14th of April. And again, I would like to comment on the fact that it was at the time of diagnosis, in terms of the testing, that he was found to be symptomatic. So he may have already been symptomatic beforehand.
That final question, could any different action have affected outcome?
I think on the balance of probabilities, probably not, but there were things that could have been done better, is how I would summarise.
Right, and antibiotics, if they weren't given, is one matter that you've identified. You've spoken about oxygen.
So, giving the oxygen, I'd like to know that it was effectively given. So that would be the comment there. The use of bacterial antibiotics, it would be good practice in this setting. That would not have been unreasonable. But on the balance of probabilities, it probably wouldn't have made a difference.
Professor Cole?
I'd agree with that. I note he was already on oxygen from an oxygen concentrator. He had that normally. So I guess, and I defer to Professor Katsimbos on this, but I guess he would need more than he was having with his oxygen concentrator because that's quite a low flow rate. And certainly he had a delirium. Whether sending him to hospital would have been a good thing, I think it certainly would have meant that his oxygen saturations would have been monitored and maybe there would have been better treatment and also, of course, the possibility of antibiotics. So that's a possibility, but he did have so many comorbidities. His likelihood of survival was probably quite low, even if he'd gone to hospital.
Thank you. Professor French?
Yeah, I concur with my colleagues and agree that on the balance of probabilities, there was no effective treatment to prevent his death.
Thank you. Can we turn now to Mrs. Edith Brownlee? First of all, in terms of cause of death and whether there are any contributing factors, and I think what I'll start doing now is going in the same order so that I don't miss any of you. Professor Katsimbos?
So COVID-19 infection, and because of the suddenness of the death, a cardiac arrest, the underlying ischemic heart disease. I note that she'd had coronary artery bypass grafts.
Thank you. Professor Cole?
I'm probably going to disagree a bit, but I'm happy to be convinced otherwise. She didn't have any symptoms of COVID-19. Perhaps she was one of that number that are asymptomatic. She certainly died very suddenly, and I certainly felt that her ischemic heart disease contributed significantly to the cause of her death. As I said, because she didn't have symptoms of COVID-19 as such, other than a positive PCR test, I thought it was more likely to be her heart just stopped because of her ischemic heart disease.
I see. Thank you. Professor French?
I agree. On the balance of probabilities, I considered her death related to underlying heart disease.
Rather than COVID?
Rather than COVID, yeah. With COVID potentially being a contributing factor, but the primary cause was the underlying heart disease.
Thank you. Is there any...
I might just say my view here is that COVID has precipitated the problem. In the notes, it does say, although it says asymptomatic, but sneezing, wheezy, the SATs have dropped from 97 to 92. I don't think the COVID infection is the big thing here. I think she has an infection, but her underlying problem means that it doesn't need much to precipitate a cardiac event.
Right.
For clarification.
Is there broad agreement then between the three of you on this issue? Is there actually still an area of dispute there? It sounds like you've actually come closer together on this issue.
Maybe I should clarify the way I use the terms. So COVID infection does not necessarily mean, disease, pneumonia. So we know she's got an infection, so that's precipitating the problem. The cardiac disease is the biggest underlying problem here because it was a sudden event.
Yes. Professor Gould, you started off saying you're going to disagree, but you've just been nodding.
Yeah. So... No, I agree with my colleagues in that I'm sure it was cardiac, her death, but, if she was, she did have some COVID disease, some infection happening along the way, that clearly could have precipitated. So I'm quite happy to say, yep, to agree.
Thank you. Anything further on that, Professor French? All right. Now, the additional questions in relation to Mrs. Brownlee, Professor Katsimbos?
So the underlying ischemic heart disease was significant in terms of the comorbidity, and we've talked about that. I'm just going to So the only thing I would say is I did note, and as I mentioned, the falling oxygen sats when they were noted, but they weren't noted measurements weren't taken very often, so it's hard to know what actually was happening with that trajectory. So I did comment on that. Difficult to say without further clinical observations documented. So I would, but on the balance of probabilities, the suddenness, the fact that it was only the COVID precipitating the problem, I don't think anything would have changed here.
Okay, thank you. Professor Cole?
I would agree with that. Yep. I don't think anything would have changed, and going to hospital, I don't think would have had any effect on the outcome.
I agree.
Next, if we could turn to Maria James. First of all, in relation to cause of death, contributing factors, Professor Katsimbos.
So I had acute respiratory distress syndrome associated with COVID-19 infection and metastatic cancer. That's a significant contributor.
Professor Cole?
Yes, COVID-19 infection, but with the chronic lung disease, heart disease, and her metastatic bone disease contributing significantly. She also wasn't eating or drinking because she was, I think, in significant pain.
In my assessment, I thought that on balance of probabilities, her death was more likely related to her underlying metastatic malignancy, with COVID-19 being a contributing factor. So it's really whether you say that the COVID-19 was the primary factor or the metastatic disease was the contributing factor. I don't disagree with my colleagues, but I didn't come to the same conclusion.
Just where you put the emphasis.
Just where you put the emphasis. Yeah.
And what's the evidential basis for putting the emphasis on the metastatic cancer as opposed to the other matters?
Well, I guess when I must admit, I agree with my colleagues. I found the notes in general very difficult to understand and certainly limited in much detail. But from what I gathered, the highest temperature she had was around 37 degrees, 37.1. I may be incorrect. Major symptoms were pain in her arm and abdomen. She was described as chesty. So I was able, and in the preceding hours, there was a deterioration where she was sort of tired and less alert. So it was real on the symptomatology that was described that I sort of formed that view. But like I said, it's really where you put the emphasis, and it's on. You could go either way.
Is there any response to what Professor French has said from either Professor Katsimbos?
I agree.
Or
It's
Cole?
complicated. In fact, I found this one quite tricky because I'm just looking at my notes here.
Yes.
So I did note that there's all this background, so metastatic cancer from January and all the other comorbidities, and they were significant, particularly the cardiovascular. So that's in the background. But then she went to Newmarch for respite care initially with a view to permanent care. And then I note that she goes there end of March, and then 2nd of April, she has a chest infection, clearly rhinorrhea, productive cough, low-grade temperature, SATs are falling. She then goes back to Nepean and gets assessed for that. It's not COVID, but there's a possibility there even. And that's managed. And then she gets sent back to Newmarch, still has a chesty cough, and then has and then gets, sorry, she's, I've just got my dates wrong. Discharged back from palliative care to Newmarch on the 6th of April, that's right. And then there's a possibility of a pathological fracture and pain and so on. That's why she goes back to Newmarch. But the chest problem seems to progress. That's why I focused on the infection side of the deterioration being in the chest and the acute lung problem, understanding that the background problem of cancer is there and progressing and probably added to her inability to fight off the infection, if you like, in a very general sense.
Just picking up on one aspect of that answer, the reference to a pathological fracture.
Yes, it was in the notes, and that was the reason she got sent back, because they were worried, because a pathological fracture means a fracture with very little force, and that suggests the underlying bone is not normal, And in the setting of progressive cancer, one possibility is there's a cancer in that part of the bone.
Is that the fracture to the humerus that you're referring to?
Yes, yes.
Is it relevant that she had a fall on the 17th of April?
Yes.
If you assume that.
But it's hard to know how much, just from the notes, how much was the force of the fall and how much was the weakness of the underlying bone that led to the fracture.
Right. So
but in the notes, it suggested query pathological fracture. So someone has made an assessment that the level of force was somehow potentially not as great as it might have been.
But the two might have been operating together, is what you're saying. You may have had a fall.
And someone was worried enough to act on it.
Just before we move off causation, Professor Curl, is there anything you want to add, having heard those additional responses?
No, but I just know, looking at my notes, the day before she died, her oxygen sats had dropped to 89% on 3 litres of oxygen. She had a high pulse rate. She was short of breath and couldn't talk to her family. So that made me think, no, she definitely was developing that those lung symptoms, hence the yes, it was COVID-19, but it was clearly she was on a lot of morphine because of her pain. She had all the underlying problems. So it's a number of things contributing to her death.
All right. Can I turn now to the second wave of questions? Professor Consimbos?
So I think building on what I've already said, I don't think there was much else we could have done for the chest infection side of it. But I do believe that the palliative care issue in terms of her pain, her metastatic problem, particularly the pain in her arm, was perhaps suboptimal. And I think I'm just trying to see what the next of kin is. Yeah, there was a breakdown in communication and perhaps certain things were lacking in how that relationship was dealt with at the end.
Right. Is there anything specific you want to say about that?
Well, I think
when you use the expression suboptimal.
Well, I think the whole point of palliative care is to reduce symptoms and to reduce pain and discomfort. So that doesn't seem to have happened in this case adequately.
Professor Curl, your response, and noting that in your initial answer you spoke about Ms. James being in significant pain.
When you read the notes, she complained often and often to family. The family then complained to Newmarch House. We did have a more detailed look at her medications, and she was prescribed quite a lot of hydromorphone, and she didn't always get it. That being said, I'm not sure that in particular led to her death, but it could certainly, I think it could have been perhaps better managed in terms of palliative care and pain relief.
Excuse me for a moment. Professor French?
I have nothing to add to what my colleagues have said.
Thank you. Next resident who passed away was Mrs. Margaret Brocklehurst. First of all, in terms of your opinions about the cause of death and contributing factors, Professor Consimbos.
So COVID-19 infection, clear evidence of infection and symptoms and a disease process, and significant contribution by her cardiovascular disease comorbidities.
Professor French?
Yeah, I agree. COVID-19 infection and comorbidities, which extensive history, past history, but the things that I highlighted were, excuse me, her ischemic heart disease, hypertension, and diabetes as contributing.
Thank you. Professor Curl?
Yes, COVID-19, history of lung disease, also the atrial fibrillation and ischemic heart disease. She was very frail, and that would also have contributed to not being able to respond to an infection.
Now, anything anyone wants to add at this point in relation to causation? Okay, then moving to the follow-up questions. Professor Zimbos.
So I actually note in this case that oxygen support was relatively well given and documented, and empirical antibiotics, a form of empirical antibiotics was used. She died comfortably, fairly suddenly, but comfortably. I do note that her diagnosis of infection was on April the 17th, so it's now getting a little bit further away from that first wave. So there's always the possibility that it should have infection control measures been significantly better. Some of these following waves might not have occurred. So I'll just leave that in the framework. But fundamentally, this was a frail person that once it didn't take much of an infection to cause problems. And so I'm not sure that anything else could have been done. And in fact, her care after the infection had been, after she got the infection was good.
Professor Curl?
No, I would agree with Professor Kotsimbos. I don't think there was anything else that could have been done in view of her multiple comorbidities, which were, I think, reasonably well managed.
I concur with my colleagues.
Thank you, Professor French. Next, can we turn to Mr. Keith Smith, please? First of all, on the issue of causation, Professor Kotsimbos.
COVID-19 infection, significant contribution, and a significant contribution probably from his underlying diabetes and cardiovascular disease, but predominantly the COVID-19 infection.
Thank you. Professor Curl?
Yes, COVID-19 infection contributed to by the fact that he was frail and chair fast from his diabetes, his his dementia, his diabetes, and his hypertension would all contributed to that.
I agree with my colleagues. The cause of death was COVID-19 with the comorbidities mentioned by them.
Thank you. If we can now turn to the follow-up questions. First of all, Professor Kotsimbos.
We've mentioned the comorbidities. I think his care, oxygen use was appropriate as far as I could ascertain. No empirical antibiotics were given. It's not unreasonable in this situation to consider them because his deterioration was quite slow, so there could have been another event. But on the balance of probabilities, I'm not sure that the outcome would have been different. Again, sorry, this person was infected on the first wave, so I think there's nothing extra that we can say about likely limiting the chance of getting the infection.
Just bear with me for one moment. In your report, Professor Kotsimbos, page 44, at point 2 on that page, when asked, could anything further have been done to prevent the fatal outcome, your response was unlikely following significant clinical deterioration, but possibly prior to this. See responses to questions 1 and 5 in this section. Question 1 referred to oxygen use likely appropriate, no empirical antibiotics used as far as could be ascertained. And question 5 referred to improved clarity regarding responsibilities, poor communication between the hospital and the home team and Newmarch House.
Yes.
And then you've also raised an issue about clinical handover details not clear. Are any of those matters...
They're important, but they're difficult to discuss because I don't have specifics. I suppose the first thing I've mentioned, it would not have been unreasonable to give this man some empirical antibiotics. I don't know that it would have changed the outcome, but you know, if you did it 10 times, maybe one would or a few would. So that's the first comment. The second comment is tricky because when there's lack of communication and you don't know what you're dealing with, how do you know you didn't miss something? And all I can say is there was lack of communication, there was frustration, there were missed calls, and it's hard to know what was happening. So that's really what that referred to, but I didn't have a specific thing to say there.
Right. Professor Curl?
No, but I note what my colleague just said, and that is important. He was moved, Mr. Smith was moved to another part of the facility. That will have upset him. He had 2 falls following that as well, which I guess is to be expected, but I'm not sure how they would they would necessarily manage them. I was also interested that he was ordered anticipatory medications on the end-of-life medications on the 17th, which was the day after he was positive, which was kind of assuming that he was going to be palliative. And I did find that somewhat interesting. Whether doing anything else would have helped, certainly that's interesting about the antibiotics. Whether moving him to hospital so he could have been monitored more carefully would have improved his care, I really can't comment on.
His age was 82. Is that a relevant matter? Or is that a simplistic approach just to look at the age in terms of his prospects or prognosis?
Yeah, I guess I come back to what I said earlier when we talked about age and frailty, and it's probably the level of frailty that is more important than his chronological age. We sort of think about biological age, and clearly with all his comorbidities and the fact that he was chair fast, he wasn't moving himself independently, indicates his probably quite high level of frailty and dependency. So it was partly that. I wonder if they just felt he wasn't going to make it, so he had those medications ordered, immediately after a positive swab, whereas it was, a week before he actually, before he died. But he certainly was frail, and I don't think taking him to hospital necessarily would have improved his outcomes.
Can I ask you to assume that in almost all of the cases here, anticipatory medications were ordered upon a positive COVID result being returned? An explanation that's been given for that in the evidence is that they needed to be in place in the event that the circumstances required their administration, given that these people, the residents, were being treated in the hospital, in the home environment, in the aged care facility. Is there a comment you want to make about that set of circumstances?
My answer to that would be they were in hospital in the home. This implies a reasonable level of attention paid to this, and I would have understood, as happens in other situations with other illnesses in other residential care facilities, those medications would be prescribed when it was clear they were going to be needed. There could be the issue of supply, and there needed to be a prescription so that the pharmacy could supply the medications. That could also be a reason. But they were in hospital in the home, and one assumes that means fairly regular attention to these sorts of areas. So, yes, I'm glad you brought up that it happened quite often. It may have been a decision they made early on that they would do that for all the residents. I won't say any more at this stage.
Right. Well, I might just ask you one follow-up question. From a clinical perspective, are there potential problems with prescribing medications of that kind in this fashion?
I actually discussed this with a number of my colleagues who work in residential aged care, and they said when end-of-life medications are prescribed, there is the assumption that the person is therefore coming very close to the end of life, end of their life, and that this can create perhaps expectations about the care of that person. Now, that's purely, anecdotal. I don't have a lot of evidence for that, other than it's certainly something I've observed myself. Where there's appropriate palliative care, talking to my palliative care colleagues about this, they would not consider prescribing it until it was clear they were going to be needed, because it can change people's attitudes to care. If someone clearly is being prescribed morphine and midazolam and glycopyrrolate, which are, to ease the passing of somebody.
Mm. And is the effect of your evidence that clearly it would have been preferable if these types of medications were only prescribed when they were clinically indicated? Noting what you said before about the need to have them to hand in the event that they had to be used.
I guess this is a compromise. I do understand they need to be to hand and that pharmacies may not be able to get them to the residential aged care facility in an appropriate time. But I still feel it's difficult to then explain that you're going to care for someone actively and, well, if you like, supportively, but have already written up end-of-life medications. But it's a compromise, and I'm looking at this with the benefit of hindsight. I'm also looking at it with the benefit of what we would have done at the time. And I suppose, it's a difficult situation. I'd be interested in my colleagues' comments on that.
Well, I might go first of all to Professor French, because I haven't asked you yet about these follow-up questions, and you might also comment on this issue as well, please.
I agree that on the balance of probabilities that no effective treatment was available for Mr. Smith, and transfer to an acute care hospital would not have altered the outcome. I guess in terms of the preemptive prescription of end-of-life medications, that is not something, and particularly in the aged care environment, it's certainly not outside. It's outside my scope of practice. But one thing I would in general make the comment is that if you are prescribing end-of-life medications and signalling your intent to transition to that the focus of treatment is transitioning to palliative care, there needs to be good communication of that with the staff, but also the patients' families as well, so they're understanding what the trajectory is going to be.
Thank you. Professor Katsinthos?
I agree with both Professor French and particularly with Professor Curl, and I think the comment I would like to make is prescribing something and making the decision to do it, to actually give it, is very tightly linked. Has to be very tightly linked, because otherwise you run the risk of a whole lot of unconscious biases playing into the decision making that can follow on and the expectations that Professor Curl mentioned, and particularly when staff are relatively not very trained and often at the level of almost personal care assistants rather than high-level nursing trained, and particularly when there's not a lot of communication. We saw here in this particular case, there was frustrated communication. So what do? Someone's written them up and we're not communicating very well. And in fact, there were many instances where they were prescribed but not given till later. So that the two have to be coupled. The prescription and the thinking of using them have to be coupled to avoid the two risks, the risk of giving it too early and the risk of giving it too late.
And just, can you expand on each I think we understand what those risks involve, but what are the risks in giving these types of medication too early and too late?
As Curl said, if we're in an active supportive mode and we give it too early, then we're not really in an active supportive mode. And if we give it too late because it's all confused and we're not really communicating, then the patient has suffered more than they had to. And I think the other thing I noted in my report was that the level of communication here was so frustrating that there were subsequent calls from Nepean, the HIT program, for regular updates because they couldn't get through. So that's significant. So there was action that followed on from the difficulties in communication.
In terms of the risks of giving too early, is it the case that one effect of morphine, that type of drug, is that it suppresses respiratory function?
Exactly. And that's one of the hardest things in my specialty to manage, where you're managing someone for a respiratory problem and you want the respiratory system to be optimal in all its parameters, the ventilation, the drive to breathe, all that sort of stuff. At the same time, you want to manage comfort and symptom relief. And getting that right is a communicated discussion. So it's a communication and a discussion and a shared decision. The other thing about giving it too early is, and the unconscious bias, is you may not do other things you might have done. So it's not the fact that you actually just gave the morphine early or the midazolam and there's a drowsiness and a certain path has gone down. It may be that you, in your mind, didn't go to other things that you had to do because that's not what you would do for someone who's prescribed this medication.
Is it the case that once a medication like morphine is prescribed, an end-of-life medication, that it's appropriate effectively I shouldn't say the word just, that it's appropriate to leave it to nurses to determine when to administer the medication?
Depends on the level of nurse, but I think there should be a medical assessment because it's about getting it right.
And who would perform such a medical assessment?
Well, in this case, it would be, and that's why the chain of command is so important, not just the person assessing, but the chain of command in terms of who makes the decisions to either titrate or down titrate the medication.
Right.
And that, in this case, I believe it should have been the HIT program leader, clinical leader.
Thank you. Anything further before I move to the seventh resident to pass away, Mrs. Leonie Corrigan? First of all, in terms of causation, Professor Consimbos?
COVID-19 infection, with some contribution from the underlying comorbidities, particularly cardiovascular.
Thank you. Professor Curl?
COVID-19 infection, again, this lady was frail, and there would have been significant contribution for her underlying diabetes and renal impairment.
And Professor French?
I concur, COVID-19 infection and significant underlying comorbidities, diabetes in particular.
And then the follow-up questions, Professor Consimbos?
So the comorbidities were significant. The decline was progressive. This person was diagnosed on 14th of April, so in terms of the COVID-19, so that was in the first wave, so it's unlikely we could have prevented the infection, so that's the first point perhaps. Oxygen was given, and that seems to have been at a reasonable level. Fluid management wasn't so clear to me, and the use of empirical antibiotics wasn't clear to me. Whether that would have made a difference, it's hard to know. Perhaps on the balance of probabilities, no, but that may, particularly the fluid, may have made a difference in terms of just a more comfortable.
What you're saying in your report at page 46.2 is unlikely following significant clinical deterioration, but possibly prior to this, as any chance of survival may have been better with adequate fluid resuscitation plan and appropriate titration of cardiovascular medications, especially given clear evidence of excess fluid losses and decreased fluid intake.
Yeah. So, and because of the significant cardiovascular comorbidities, particularly and diabetes, she was on medications to lower blood pressure and also diuretics, I believe. Yes, and diuretics. So in that setting, and then she had a diarrheal and so there were fluid losses. So I just don't know how that was managed. It was hard to assess how that was managed. Because she had a slow decline, that may have contributed. It's just hard for me to say how much that may have been contributed to her overall decline. But it could have been managed better from what I can glean was documented.
And your opinion is that may have had an impact on outcome?
It may have. I can't give you a probability for that though.
Right. Professor Curl.
Yeah, I'd agree with that, particularly around the issues around fluid. I do note that there was, I think the son queried transfer to hospital, but he was told that she would receive specialist care in Newmarch House, and it was no different to the care she would receive in hospital. I think that does become a recurring theme, but there would be the issue of adequate fluid replacement. And she was developing a pressure area as well. over her buttocks, which I guess indicates perhaps there wasn't quite the degree of care provided to her that would have been ideal. But I'm not sure whether if she came into hospital, how she would have progressed.
Thank you. Professor French.
Yeah, the contributing factors have been outlined by my colleagues. I mean, I concluded that there are unbalanced probabilities that no treatment was available to prevent death, and I acknowledge and accept what my colleagues have said about aspects of the management provided at Newmarch House.
Yes, thank you. Yes, Professor.
Yeah, just looking at my notes again, I did comment and did note and comment that there was no end-of-life pathway determined until the day of death. So they weren't thinking along that line of thinking. And she only received morphine on the last day. So it's hard to know exactly how it transpired, but if there was an active approach here, she may have been better off being transferred, this particular person, given that, you know, they weren't thinking palliative care, morphine until the last day, and it was a fairly prolonged deterioration. So I just think trying to put it all together as a package, this person may have been better managed.
In a hospital setting.
But I accept the frailty in the background and so on.
Right. Either Professor Curl or Professor French, is there anything you'd want to add, having heard what Professor Katsimbos just said?
No.
Professor Curl?
Probably just that it was a long time between her, the positive swab and her death. And that's a good point, whether had she been transferred to hospital early on, whether the outcome might have been different. She was also quite frail, so it's, I guess, less likely she would do well. But the issue of fluids and the pressure area indicate perhaps the care wasn't as good as it could have been.
We now turn to Mr. Barry Jahan, the 8th resident to pass away. Causation, Professor Katsimbos?
COVID-19 infection. There was underlying dementia and as a comorbidity perhaps, but predominantly COVID-19 infection here.
Thank you. Professor Curl?
Yes, COVID-19 and no, I didn't have any other comorbidities other than his, he did, sorry, he had diabetes and a degree of dementia, but he was still quite mobile. And yeah, he did have a positive COVID test. So, and he did have symptoms. So yes, COVID-19, sorry.
Thank you. Professor French?
COVID-19 and contributing factors being his type 2 diabetes, dementia and history of cardiovascular disease.
Is there any issue about the presence of cardiovascular disease in this case?
It's a comorbidity.
It was a comorbidity here.
It's just that you've separated them out, so it's just whether we put them in the first line or the second.
Yeah, no, I understand. Moving then to the follow-up questions. First of all, Professor Katsimbos.
So you did have comorbidities that were important, the hypertension, the cardiovascular disease and the diabetes. There were a few things I wanted to point out here.
Yes.
So the first thing is that he was diagnosed on the 3rd wave of testing, so on the 23rd of April, having had 2 negative tests on the 17th and the 14th. So this is clear evidence of there's a propagated wave in the institution. So if infection control, if you can imagine, if it was perfectly shut down in the first instance, we wouldn't have had ongoing infection. So there's an issue here. So that's the first point I want to make. And so potentially, given that we've said COVID-19 is the main cause of death here, if he didn't get infected, that would have been a much different outcome. The second issue is that it's not clear to me from the notes. I found it very difficult to work out how much supportive care he got in terms of the oxygen particularly. And the third thing, in when he was end of life care mode, the crisis meds were charted but not given. So he really had an uncomfortable end. And I think the family were quite distressed by that too. And there was also the question of suboptimal video visits and so on. But I think, so there were three things here for me. One was he was infected late, so there's a wave, and whether that could have been avoided. The second issue is the crisis meds were charted but not given when he needed them. And the third issue is the interaction with the family.
Thank you. Professor Curl?
I'd like to add to the comments of Professor Katsimbos. Mr. Gihan had the 2 negative swabs in the first 2 rounds of testing, and early on his family wanted to take him home so that he would not be infected, and this was declined on the basis that there was a public health order, which apparently there wasn't, but there were issues around that. And I think this is quite important, where family were prepared to look after him at a time when he was still negative. And I think I agree, had he not been there, or had there been appropriate infection control, he would not have got it. Well, it's less likely he would have contracted COVID-19. So that does concern me a bit, or it does concern me quite a lot. There's also that he had an advanced care plan that said he did wish to be transferred to hospital if this was appropriate. So there are a number of things there that make me worry a little bit about the care, but it concerns me that the family did want to remove him from a potentially infective situation, and they were prevented from doing so.
Had Mr. Jahan been taken to hospital at an early point in time, would that have had an impact on his trajectory?
He certainly didn't have a positive test till the 23rd, and I wonder if he was symptomatic then because he actually had a fall on that day, and there was the query of a possible urinary tract infection. Whether that would have made a difference to his outcomes because he died 5 days later, look, I don't know. I suspect it may have helped, and it was his wish that he be transferred to hospital if it was appropriate.
Thank you. Well, I'll go to Professor Katsimbos first.
I wanted to just emphasise the fact that he did, as Professor Curl said, have a standing order for hospital transfer, which was interesting. But and that wasn't followed. But the extra thing for me was there's no evidence in any of these cases how much infection control procedure is actually being followed. And I just wanted to use this opportunity to mention it here particularly, in terms of PPE of the staff, in terms of movement between rooms, in terms of patients being moved in and out of the facility. And I think that's an important consideration here.
Yes. On that front, there's been a great deal of evidence about the subject of infection prevention and control, as you would expect. And there is controversy, I anticipate, in the inquests on those subjects. There certainly has been evidence given by, for example, nurses who were present at the scene, senior nurses who came in to manage the facility, for example, that there were lapses or undesirable practices at various points in time. But perhaps by way of background, this is one of the areas of interest to the inquest. There's a great deal of evidence that's been taken on the subject. It's not an easy matter to synthesise uncontroversially. So you're giving evidence in that context against that background.
I understand that, but I think it's very clear there's a propagated wave of infections. So they're spread with institution. And this is just looking at the evidence from the 19 deaths. I haven't factored in the 18 other patients, residents that were positive, and I haven't factored in the staff that were positive.
And of
So
course,
the issue is for me, there's clear evidence of a propagated wave. The question of the mechanism of that, I'm open to the epidemiology experts with extra information to tease that out. But there's clear evidence for me that there's a wave,
and
a propagated wave.
as someone who has expertise in the area of infectious diseases, this is an issue, I take it, that you feel that you can comment on and provide an opinion about.
That's right. And I think it's particularly relevant in this sort of infection because the problem with infections like COVID is a lot of the spread occurs before symptoms are there. So unless you have practices in place, you'll miss the opportunity to control. It's very different if someone gets the symptom and then you isolate them. We've got no signal here. You have to have protocols to limit the spread.
Again, I don't want to simplify the evidence, but one distinction, perhaps, between what happened at an earlier outbreak at Dorothy Henderson Lodge and the Newmarch House outbreak is that with Dorothy Henderson Lodge, a practitioner who had expertise in the area of infection prevention and control came on site very early and set the ground rules for infection prevention and control, which was not the approach taken at Newmarch.
I might just add also that I do sit on our hospital's infection prevention committee and have done for many years.
Right, thank you. Professor French.
Yeah, I agree that once Mr. Jahan contracted COVID-19 and his condition deteriorated, that no effective treatment to prevent his death existed. I did note that his advanced care plan completed in June 2019 indicated he wished to be transferred to hospital medically indicated, but I also noted that that plan was revised on the 25th of April, and the clinical record indicates that was discussed with Mr. Jahan's daughter.
Is there anything further you'd wish to add about the issue of whether an earlier hospitalisation prior to deterioration could have made a difference?
I accept my colleagues.
Thank you. The ninth resident to pass away was Mrs. Shirley Yates. Can I ask you first each about the issue of causation of her death? Professor Contempt.
Yeah, we have clear evidence of pneumonia, so COVID-19 pneumonia.
Yes, and that was the principal cause of death here. Professor Curl?
Yes, I agree. COVID-19 pneumonia.
And Professor French?
COVID-19.
Okay, so there's agreement on causation. Now moving to the follow-up questions. Professor Consimbos?
She did have some comorbidities, treated hypertension, but I don't think they were significant. The interesting thing here for me was that Mrs. Yates was actually transferred to one of the patients, one of the few patients, one of the three patients, I believe, who was transferred to Nepean Hospital, but not because of her COVID illness necessarily, but because she had chest pain and there was the concern that she may have had rib fractures in relation to a fall that she had on the 19th of April. And that may have been contributing to her worsening hypoxia and ventilation problems. The chest X-ray at Nepean clearly showed pneumonia, so that we know that. And indeed, the care she got there in terms of oxygen, fluids, antibiotics, secondary antibiotics, it's unclear whether that was for the chest or a urinary tract infection, but she did have very purulent sputum. She got very good care, and in fact, she was also palliated when it was clear that nothing further could be done. In other words, supportive care had a limit, and it wasn't that wasn't excessively pushed. And she died a comfortable death in the end, with the crisis meds being given as they should be at the time they were needed.
In hospital.
In hospital. So I thought she was an interesting, I could almost say a counterfactual.
Right. Counterfactual, not in the sense that something that.
In terms of something good happened by.
Counterfactual in the sense of how she was given care in her last moments.
That's right. That's right. In a hospital setting.
Okay, thank you, Professor Curl.
No, I'd agree totally with Professor Katsimbos. I don't have anything to add.
Okay, thank you, Professor French.
Nothing to add.
Thank you. The next patient is being just referred to by an acronym, CA, but hopefully you understand which case we're talking about. Does anyone have any doubt about this? About who CA is? In terms of answering questions? No. Okay, good. First of all, can I ask in terms of causation, Professor Katsimbos?
COVID-19 infection and underlying contribution to dementia, perhaps, but predominantly COVID-19 infection.
Professor Curl?
Yes, COVID-19 infection, underlying vascular dementia, and she also was chair-fast. She wasn't independently mobile. And that would contribute in terms of frailty.
And Professor French?
Agree, COVID-19.
Moving now to the follow-up questions, Professor Katsimbos.
So her diagnosis occurred on the 10th of April, making her the index case. And that's important. So we can't have prevented this infection because she was the first that we noted from, unless there were staff members that were noted earlier. I noted that her care in terms of oxygen support, increased fluids and empirical antibiotics were all appropriate. So that was a positive thing. I didn't think anything else would likely have changed the outcome. I do note there were several questions related to the end-of-life palliative care approach and the family being happy with how that played out. But in terms of the final outcome, I don't think that would have changed, but perhaps it could have been done in a more dignified way.
Thank you. Professor Curl?
No, just to add to Professor Katsimbos, Mrs. CA did not want transfer to hospital according to her advanced care plan. The GP had actually suggested transfer to hospital, but the family were told that the ambulance would be reluctant and that someone from the PN had said she was unlikely to survive. It's hard to know how she would have gone in hospital because she was, as pointed out, probably the index case, and she had COVID symptoms for 18 days before she died.
I concur with the comorbidities that have been outlined by my colleagues, and also on balance, I believe that there was no effective treatment to prevent her death.
Thank you. It's 1 o'clock, Your Honour.
Yes.
I am concerned about the rate that we have to obviously address each of the 19 cases, and if I can say this, the professors are giving evidence in a most efficient manner. That's my observation. But I am concerned that we're going to be time pressed this afternoon. There's still quite a bit of territory to cover. I'm not sure whether Your Honour's open to a shorter lunch, for example.
Yes, I was going to suggest we might continue perhaps for another 15 minutes and then resume at 2 o'clock with a shorter lunch if that's convenient.
Thank you. I'll keep going. The 11th resident to pass away was Blanche Billinghurst.
COVID-19 infection, vascular dementia as a comorbidity.
Professor Curl?
Yes, COVID-19 infection and yes, underlying comorbidity of vascular dementia and osteoarthritis. So she wasn't moving a lot.
Professor French?
Agree. COVID-19 infection with an underlying diagnosis of dementia.
Can I ask you now about the follow-up questions, Professor Katsimbos?
So there were other comorbidities here. There was some lung disease, some other cardiovascular risk factors, cardiovascular disease problems, particularly hypertension. it was unclear to me how severe her chronic lung disease was and how it was managed. The supportive care in terms of the oxygen seemed reasonable, so that encourages me. She did need a bronchodilator for her airways disease. It was hard to know how that was being given, by spacer, by nebulized, what was going on there, and whether that was adequate for her. And it was hard. It wasn't clear to me whether she had had empirical antibiotics or fluid supplementation. Noting that, I'm just trying to see, that it was quite a progressive decline, 14 days from the time of diagnosis. But she was again someone that was diagnosed in that first wave, so it's unlikely we could have prevented the infection. So this was also a patient that there was some distress both from the patient's point of view and the family's point of view, because this was one where the oxygen cylinder ran out.
That's right.
That was,
I'm going to take you to that particular
so
circumstance.
that was both specific in its problem and also symptomatic of what else may have been going on.
And what is to be drawn from that circumstance?
Well, it's unusual for, usually we take care for that not to happen. So the fact that happened is of concern. And also the fact that, how that was dealt with and as an index problem, if you like, in terms of the nursing home. I got the sense reading through the notes, and I've just made a comment here, that overall the feeling was that everyone was feeling overwhelmed, not particularly the nursing staff and the caring staff. So it just struck me that, what else perhaps wasn't being dealt with.
Any issues that you had about fluids?
Yes, I did have some. It was just hard to know how that was being managed. There was... That's right. The family were very keen for fluids to be given. I'm sorry, I just missed my notes there. And deeply regretted that not being done. And there was also a delay in the crisis medications being started, and then on the flip side of it, the morphine dose at the end being double what was expected. So it just seemed a lot of things were not quite right for the thing that needed to be done.
I believe that there was evidence, or there is evidence, that the family were with Ms. Billinghurst on the 24th of April and raised issues, was that the occasion? Raised issues about their mother being thirsty, for example.
Yeah, so there was that. There was when the oxygen cylinder ran out, the oxygen levels fell down, low sats, I think in the 60s somewhere, and then obviously improved when they came up. And how long were they low for? There just seemed to be a whole lot of things that were being tended to properly.
But these are sorts of factors that can have an impact.
They can, and the worry is that each one of them perhaps not so much, but all together, and then as a package, maybe also signifying other things that we haven't noted. I think on the balance of probability, they may have had an impact here.
In terms of different outcome. Is that what you mean?
Possibly. It's hard to know.
I'm just trying to understand when you say on the balance of probability.
Different outcome, possibly, yes.
All right.
Because it was and I'm particularly saying that because it was a slow progressive decline. So all these things I can imagine a situation where they all add up.
Mm. And putting aside the issue of whether there could have been a different outcome, are these sorts of matters that you've just been giving evidence about, will they impact on the comfort of the patient?
Oh, certainly. So that I can be a lot more confident about that. And I can also flag the fact that if so many errors are happening and there's frustration, there may be a lot more. So that's an issue as well for the whole system. The system is cracking here a little bit.
Right.
And actually, as the cases progress, because we do have a chronological order here, you see that more and more. You see less, if I may, you see less notes being taken, you see more frustration, you see less documentation generally, you see questions being asked and responses being quicker and a little bit sharper, perhaps, as a general thing.
Professor Cole.
In terms of comorbidities, the vascular dementia, I think, is important because Mrs. Billinghurst was asked about her advanced care plan. And there was a question raised by her son whether she was actually competent to be the one to be asked or whether he, as person responsible, should have been asked. She also had hypertension, osteoarthritis, and a past history of a hip fracture. I think to add to the list of things that didn't go quite right, Mrs. Billinghurst had selected transfer to hospital. And when discussed with this son, he also said he would like transfer to hospital, but would agree with what his mother wanted. But on the 24th of April, an ambulance was called to take her to hospital by nursing home staff, and this was then cancelled by somebody at Nepean Hospital who stated that she'd get the same care in Newmarch House as in hospital. So I think that's another, to add to the empty oxygen cylinder and perhaps a number of other things that didn't go very well for this lady. But I am concerned that her wishes weren't necessarily followed, and neither were those of her son as her person responsible.
Paragraph 90 of your report, page 12, you say oxygen given at 2 litres per minute via nasal prongs is a very minimal amount of oxygen. Family queried why she could not be given IV fluids when she was clearly distressed by thirst. No suggestion made about subcutaneous fluids, although morphine was being given subcutaneously. Do you want to comment or expand on those comments?
That certainly she'd complained of thirst, and as I've mentioned earlier in this hearing, subcutaneous fluids, normal saline given, is a very appropriate way to assist that and is used fairly often in residential care facilities. It's not like they weren't using butterfly, the needles that can be used to give subcutaneous fluids, because they were using them for morphine. I guess I would have been happy to see that perhaps her thirst issues were addressed with subcutaneous fluids. I understand that intravenous fluids are not ideally administered, even though we are talking about a hospital in the home.
And your earlier comment about minimal amount of oxygen, is there a suggestion there she should have been receiving a higher flow of oxygen?
Yes, I think that's what I was looking at there. I'm just trying to find my records of her oxygen saturations. I've just got noted that they decreased significantly, but I didn't put in levels, so I'm sorry about that.
Just moving to the final question in this series of follow-up questions, which is whether hospitalisation at an earlier point could have made a difference with someone like with Miss Billinghurst. What's your opinion as a geriatrician?
Look, she would have benefited from fluids, from better management of her oxygen levels. I think she's a lady who could well have benefited from going to hospital. She'd had 2 weeks of COVID. It was going very slowly, and I think better care may well have resulted in a different outcome for this lady. So this is someone that I did think may well have benefited from being taken to hospital very early on in her illness.
Thank you. Professor French.
Yeah, I did note that Mrs. Billinghurst had advanced care planned, which indicated that she'd be transferred to hospital medically indicated. I also noted that that the ambulance was called on the 24th, and there appeared to be a conversation between multiple parties somewhere around midnight to 2 a.m. And following those conversations, that a decision was made to provide comfort care and not transfer her to hospital. Obviously, having those conversations over the telephone and at 2 a.m. is potentially a very, very challenging situation for everyone that is involved. I agree with my colleagues that given the patient's particularly wishes to be transferred to hospital medically indicated, aspects of her fluid therapy could well have been improved or different during her in the 24 hours preceding or 24 to 40 hours preceding her death. Whether they would have changed the outcome, I'm uncertain about. It's really, again, one of those things where you put the emphasis on. Overall, I formed the view that it probably wouldn't have prevented her death, but I could easily see how someone could come to that view as well.
Thank you. Can we turn to Mr. David G, who passed away on one of the 4 residents who passed away 4 or 3? 4. On the 28th of April. 3. One of the 3 residents who passed away on this day. First of all, in terms of causation.
The COVID-19 infection and I know that he had acute respiratory distress, so infection involving the lungs clearly, and significant contribution from his ischemic heart disease and more general cardiovascular disease.
Thank you. Professor Curl?
COVID-19 infection with contributions from his significant ischemic heart disease for which he'd had bypass grafts. He also had atrial fibrillation and diabetes and vascular dementia, which would all contribute to his death.
Professor French?
I agree, COVID-19 infection with the illnesses listed by my colleagues.
Thank you. And now, if we could turn to the successive questions. Professor Katsimbos?
Significant comorbidities were all related to his cardiovascular disease profile, and we've talked about that. He was diagnosed on the 18th of April, so again, this is more than a week, 8 days after the index case, so there's been propagation. So the first issue is, could that have been prevented? The second issue is with his progressive, clearly there's a clear history of progressive infection involving the lungs, hypoxia. In fact, the patient himself starts giving up and wanting to finish things off, and it's quite sad to read, really. And then, as a general, he supported well with oxygen, and he moves to palliative care fairly quickly and efficiently. And I think the next of kin were very comfortable with how that was managed. So I think there's nothing extra in terms of managing the patient post-infection. Whether the infection could have been prevented is a question.
Thank you. Professor Cole?
Agree with everything that's said in terms of comorbidities of ischemic heart disease and atrial fibrillation and diabetes and vascular dementia. I note that prior to the outbreak, when there were issues raised about COVID infection, his family actually asked if they could take him home, and they were told that he only had a certain amount of social leave and that he would get better care in Newmarch House. So I mentioned that, I guess, purely as a lost opportunity, that perhaps he may have done better at home. Other than that, I have no comments about his care, and I'm not sure things would have changed with admission to hospital.
Thank you. Professor French?
I concur with my colleagues.
Thank you. Your Honour, the time.
Yes.
That's convenient.
It is, thank you.
Thank you.
Professors, we're going to pause there, and apologies for taking a shorter lunch break, but we're going to resume at 2 o'clock. Thank you. I'll adjourn until 2 o'clock.
Thank you, Your Honour. Professors, can we please now turn to Victor Stone, who was the 13th resident to pass away on the 30th of April. First of all, in terms of cause of death, Professor Katsimbos?
COVID-19 related lower respiratory tract infection.
Professor Curl?
COVID-19 respiratory tract infection on a background of dementia and schizophrenia.
And can I ask Professor Curl, the schizophrenia, would that have had any relevance in terms of cause of death? I know that that's there as a comorbidity, if that term can be used, but would it have been a contributing factor?
In terms of his ability, I think, to care for himself perhaps and to understand what was happening to him, that was particularly where I'd use it, although the possibility of dementia, probably frontotemporal dementia, is also there as well.
Of course, that would depend on the severity of those conditions, correct?
Oh, sorry, yes, yeah.
The extent to which they are contributed. Professor French.
Yeah, Mr. Stone had a positive PCR test on the 14th of April and died some 16 days later. There's no dispute that he had infection with COVID, but I was unable to sort of clearly say whether it was the cause of his death. I did note that he had a significant number of mechanical falls, and I was concerned that there may have been an alternative diagnosis to his death than COVID-19, a neurological diagnosis potentially related to falls.
Can you identify some?
He may well have had a head injury of some description,
yes,
causing some sort of intracranial pathology, which led to his death. But he did have COVID-19. But I said he had a temperature of 37.5. He had a slightly sore throat on the 18th. He had a bit of a cough on the 22nd, and then a bit of a sore throat on the 23rd. And then after that, he seemed to deteriorate from a conscious level following those falls. So it may well be COVID-19 that's caused death, but I kept my mind open to other potential diagnoses.
Yeah, there's quite a significant delay between the time of the first positive test, 14 April, to the time of death, 30 April. 16 days or so. So that, I take it, is relevant to what you've just said.
Yes.
Professors Katsimbos and French, is there anything you'd wish to add, having heard what... Katsimbos and Curl, is there anything you'd wish to add, having heard what Professor French just said?
Just looking at my notes here, I think there is a long gradual decline, then a late phase acceleration. It's hard to know if it's not documented whether there's anything else that's happened that may contribute. I think the only positive signals in the notes all relate to headache, unwell, sore throat, lethargy, but the oxygen sats, although they're above 90, have fallen from, they were higher, 95, 96%. I still think it's likely that the COVID has contributed significantly to the cause of death. Whether there's another factor, it's very hard to say.
Thank you. Professor Curl, anything further on causation?
Yeah, look, I agree about the fall on the 22nd. And then after that, he had some pain and then gradually deteriorated. So whether there was something else going on as well, but I think it was because he had a COVID-19 infection that he'd had the fall. So that would be my cause of death.
Can I now move to the follow-up questions, Professor Katsimbos?
So here along the lines of your lead, the comorbidity, significant comorbidity, dementia, schizophrenia, and I thought the diagnosis being made on the 14th of April meant that he was part of the first wave, so I don't think there was any real chance of preventing an infection here, which I think is an important point. I note that he was given some oxygen, and his oxygen sats, the ones that were measured, were all above 90%, so I thought that was appropriate. I didn't think there was anything to suggest that the outcome would be, could have been different, but I do take Professor French's point that there are some unknowns there. I did also note that his overall, his end-of-life care was reasonably good, and it was a comfortable death. Although that's largely commented on by the nursing staff, the next of kin made some comments that were a little bit in disagreement with that.
Professor Curl?
No, nothing else to add.
Thank you. Professor French?
I can concur with my colleagues.
You concur. The 14th resident to pass away was Anne Fay, who was 76 years of age. She died on the 2nd of May. First of all, in terms of cause of death, Professor Katsimbos?
COVID-19 pneumonia.
Okay. Professor Curl?
COVID-19 pneumonia.
Professor French?
COVID-19.
Right, so there's complete agreement on that issue. And in terms of those follow-up questions, first of all, Professor Katsimbos?
This was a complicated case, and if I just go to the comorbidities, there were significant comorbidities. There was cardiovascular disease, chronic lung disease. There was a cervical spine problem that wasn't fully elucidated, and there was some mild cognitive impairment. The key point I would like to make here is that her diagnosis was on the 29th of April, which makes her the latest one diagnosed, the latest resident diagnosed of these 19 deaths. And there were 4 negative tests beforehand. So that does suggest that she's acquired it very late. And again, the issue of a propagated wave and a spreading infection within the nursing home. So the first thing to say is, could that have been prevented? And that's an important point. The second issue is that she was, there was clearly an illness related to the COVID-19 problem likely present even before she was diagnosed, because she had symptoms of being confused and fevers and tachypnea for several days before she was diagnosed. And then when diagnosed, there was also the problem of diarrheal illness, which is not unusual in a COVID-related infection, and then increasing confusion. And because of the confusion, hypotension, and a few things that weren't clear, she was actually sent an opinion for further assessment, and she was managed in an ICU setting initially, and in fact did receive quite a lot of support, diagnosed as a COVID pneumonia. And although she got all this support, the actual the feeling from particularly from the family, was that a lot of this support meant that her end-of-life care was rather distressing and not as comfortable as it could have been. So there was a tension between the extra support being given and it not making a difference, and in fact not making a difference, leaving the next of kin particularly unhappy that a lot of extra things were done that were perhaps not necessary.
Mm. In the wash-up then, was this a case where a different form of care, for example, care in a hospital, could have made a difference? And the reason I ask that question is that in your report at page 60, where you deal with this issue, you haven't used the formulation which appears in other cases unlikely that there would have been a different outcome. Here, yeah. Oh, sorry.
So what
I've gone to the wrong page.
I have actually.
Yes, so unlikely in the setting, very rapid COVID-related clinical deterioration, especially given the degree of clinical support received in the end, but possibly prior to this, regarding infection prevention.
Yeah, it was the infection prevention that I highlighted at the start. That was the issue for me.
I see.
And not getting the infection would have made a huge difference here. Once she had the infection and the progression was quite rapid. In fact, the care was very good in terms of the assessment and so on, but not necessarily in terms of the comfort and end-of-life management side of things.
Right. They were suboptimal. Is that your opinion?
From what I gathered from the notes, yes, and particularly the next of kin's perception of it all.
Professor Curl.
I'd agree with the comorbidities. She certainly had heart disease, lung disease, hypertension, osteoarthritis. I note that she did have an advanced care directive saying that she wanted all interventions. So whether that was a reason she did end up in intensive care and intubated. Otherwise, no, I agree with everything that's being said, and that she was fairly late to be having a positive swab. My other comment was she had been very good with her isolating and apparently had not gone outside her room, and as we've said, had previous negative swabs. So the question was, how she caught it and whether that could have been prevented, as Professor Katsimbos has already said.
Yes, Professor.
It was something I've just seen in my notes. So there was the initial infection side of things, and then there was confusion that was felt to be beyond perhaps the presence of the infection that was happening at the time. And there had been a fall, and there was a specific question raised about intracranial hemorrhage, and that was the reason for the transfer. And having been transferred for this reason, and her being unstable for a CT, she ended up having a lot more things that perhaps she needed to in terms of intubation and so on that didn't make a difference. And I think that was the particular thing that was disproportionate.
I see. Professor French?
I agree with my colleagues, and I think part of the reason for intubation and mechanical ventilation was related to a clinical condition, but also to facilitate further investigations consequent to the fall that she had as well, which was one of the reasons that she was transferred to hospital, and particularly probably a computerised tomography of her head to rule out an intracranial pathology.
Thank you. The 15th resident to pass away was Mr. Vidakovic, Marko Vidakovic. First of all, in terms of cause of death?
COVID-19 related lower respiratory tract infection, and he'd had a cardiorespiratory arrest. And a significant comorbidity was his dementia, I think.
Thank you. Professor Curl?
Yes, COVID-19 infection, dementia and the history of stroke.
And Professor French?
I concur.
Now, in terms of the follow-up questions?
Other significant comorbidities were his cardiovascular illnesses and some chronic lung disease, both of which were being treated. He was again diagnosed on the 19th, so a bit later. So again, several waves into the propagation of the infection at Newmarch. So raising the question, could it have been prevented? He had a clear respiratory infection syndrome, was given oxygen. Difficult to say that this was effective, particularly given his cognitive state. And both in terms of the dementia, perhaps a language problem, and subsequent confusion. It was very, I suppose, one of the things that really struck home for me is he was under the care of a public guardian, and I think a lot of good questions were asked and a lot of things were checked, in fact. But the one thing that did strike me as important, and I found it a little bit sad that it was missing, was no real attempt was that made to during this admission and during these events to talk to him in his language. So it's very hard to know how much of all that confusion was that there was a language problem. It was just hard to know, and maybe that had been sorted out previously, but I can't really comment to that. And I always like to give the benefit of the doubt to the patient and try and understand whether we're missing something in terms of the language.
This is that part of your report where you talk about the fact that no attempt was made to use a Serbian interpreter.
Yeah, and there may have been something that he understood. I understand he was cognitively impaired. I understand he was demented, but there may have been some transferal of information that may have improved his care. I'm speculating a little bit, but I'm not speculating on the fact that there was no attempt made.
If you were treating this person in the Royal Prince Alfred Hospital, would it be...
I would try to get an interpreter, at least to make that assessment. Otherwise, I'm guessing.
Right. And when you say... what you're indicating is that it's an important part of diagnosis and treatment to obtain feedback from the patient about what they're feeling. Is that what you're getting at?
Yes, and I understand his primary language is Serbian. I don't know how good his English is. He clearly has a problem with cognition and dementia. He was clearly confused, but how much of that confusion was related to just not understanding what was going on and so on, how much was the illness, it's hard to say. Yes. And I do think it's always important to give the benefit of the doubt to the patient.
In your report, at paragraph D1 on page 63, you say there's O2, I take it that means oxygen supportive care suboptimal.
Yeah, and that's...
What did you have in mind there?
Largely because he was taking his mask off and it wasn't being checked properly. It was just difficult to manage him. Related to his mental state. Thank you.
Professor French, Curl?
No, I agree. The dementia, the stroke, and he was aphasic. I think there had been an attempt with a Serbian interpreter when he'd been in Nepean Hospital prior to placement, but certainly I agree there did not appear to be an attempt to communicate with him in Serbian, if indeed he could understand it. And yes, he had hypertension and chronic airways disease, all contributing. I think the Public Guardian had approved his palliative care plan, and I think that was done very appropriately, and I'm not sure anything else would have changed his outcome.
Professor French.
Yeah, I concur with Professor Curl. I agree that there's probably no effective treatment that could have changed his outcome, and that appropriate palliative care review was provided.
Thank you. Olive Grego, 88 years of age, passed away on the 5th of December. First of all, can I ask about her cause of death, please?
COVID-19 infection, significant comorbidities, widespread vascular disease and dementia.
Professor Curl?
Yeah, COVID-19 infection, secondary causes, her significant dementia.
I concur.
Thank you, Professor French. And then in terms of the successive questions?
The key comments here again, diagnosed on the 23rd of April, so 3 negative tests beforehand, so quite a way into the spreading infection. Developing symptoms on the 22nd, so interestingly, she was diagnosed on the following day, a test was done the following day, not on the day of the symptoms. This is a general comment. It looks like she got some empirical antibiotics for a potential urinary tract infection. It wasn't clear how much oxygen support she got, and indeed, I found the notes after the 24th, so after the diagnosis, very sparse. In fact, observations being quite limited. That was confounded, in fact, by messages to the family that the situation had improved, particularly in terms of saturations and getting that wrong. Yeah, so the key things for me here were the late infection into the epidemic and the minimum documentation after diagnosis.
Which clearly makes it difficult now
to say whether anything else could have been different. Yeah, I'm just trying to see what the end-of-life care plan happened, how that played out. So even that was quite a protracted affair. The crisis medications were over 4 days, and the interactions with the family were perhaps not ideal in terms of what they were being told and what they expected. There were some erroneous messages that they and I can understand it from the staff point of view that a lot was going on, but there were some specific messages that the family received that were not the right messages for this patient, which were very distressing to the family.
Professor Curl?
No, I would have to say I agree. The comorbidities were particularly her dementia and her very poor mobility, and yes, peripheral vascular disease. So there are a lot of things going on. I think it was her dementia that contributed a lot. She probably wasn't able to cooperate with all treatment. I don't think I felt there was anything more we could do to change the outcome.
Professor French?
Yeah, I concur. I can also concur that the notes were particularly sparse here.
In this particular case. And I'll come back to the notes after we finish going through the individuals. On the 8th of May, Faye Rendorf passed away, having tested positive back on the 17th of April. First of all, in terms of cause of death, Professor Consimbos.
Related pneumonia.
Professor Curl.
COVID-related pneumonia.
Professor French.
I've said, I actually said the problem balance was probably related to ischemic heart disease. She had COVID, and COVID being a contributing factor because of the negative COVID, principally because of the negative COVID test obtained on the 5th of May. So she'd had recent COVID, but then had cleared COVID at the time she died. But that, no doubt the recent infection was a significant contributing factor.
There was a negative COVID swab taken, I understand, on the day before her death.
On the 5th, yeah.
The 5th, yeah.
Right. Does anyone wish to respond to what Professor French has just said in terms of cause of death?
I can add to it as we go on.
Okay. So can we move then to the follow-up questions, Professor Simpos?
Significant comorbidities being her ischemic heart disease, cardiovascular disease generally, chronic obstructive lung disease, and she had been noted to have multiple falls and fractures. I take Professor French's comment that the 5th of May she had a negative test, being positive on the 17th, but negative on the 14th. So she was sort of in the second wave of infections. The respiratory infection syndrome is quite clear though, and even on the 3rd of the 5th and the 4th of the 5th, it's tachypnea, hypoxia. So I think there is, it's likely that she's got COVID-related infection that's progressing down the respiratory tree. It's not unusual as the infection to progress that we have infection lower down, but we only sample up here. So that may clear, particularly, and not necessarily clear, but be below the detection threshold, yes, particularly if the swab's not done particularly well.
Right.
So of the two possibilities, I favour she's still got infection. It's just that we didn't pick it up in that the way it was done.
Yes, and
just
for the record, you're indicating.
Oh, sorry. The upper airway.
The upper airway,
which is where the
facial area.
Yeah, the nose and the throat.
Right.
Sorry. Yeah. So, and then I think, again, I'd like to comment on the fact that the notes were not good at all in terms of how much oxygen she was getting. The documentation was quite poor. It was only 1 or 2 documentation. She was given some antibiotics for her chest, so there's concerns about the chest changing. So that fits in with the lower respiratory tract being involved and so on.
Does the negative COVID result mean that she was overcoming the COVID illness?
Not necessarily. It can be, because I think there's still evidence that there's something going on in the chest.
Is this a case where earlier or different forms of treatment might have made a difference?
I don't think so. It's so hard to answer that question without the notes, without documentation in the notes. I would say, given her high level of care, her significant comorbidities, probably not. But exactly how much oxygen she was given, how much fluid support she was given some antibiotics, it's just hard to say. I think what we can say is that we could have been more sure of the level of care that was given if she was perhaps, if better attention was given to that. And I do note that the end of life aspects of her care were particularly difficult from the infection control point of view and the family visiting and so on. So that might have been able to be handled better. I dare say the final outcome wouldn't have been different on the balance of probabilities, but perhaps it could have been a lot better managed.
Thank you. Professor Cole?
I agree her comorbidities were particularly her ischemic heart disease and cardiovascular disease, but the past history of anxiety and depression may have contributed in terms of her coping with the issues. I know, she was a long time between positive diagnosis and death. I was just trying to add it up, 20-something days. I wondered whether she would have benefited from perhaps hospital admission following her positive swab. She was, even though she was 92, but it was a long time between positive swab and symptoms starting. I also note her advanced care plan requested all interventions.
Right. And is there anything in particular about hospitalisation that could have made a difference here?
I think just observations and the supportive care she would have received there. I wonder what was happening, to her electrolytes, to her fluids. Because there wasn't a lot of documentation, it was hard to know what to do. But the family certainly were concerned about the lack of food that was provided to her and the assistance, with care. So there were a number of things that may have been much better looked after in a hospital situation. She certainly had quite a lot of pain in back, neck, and significant agitation.
Professor French.
I concur with my colleagues that the death was probably not be able to prevent it, but hospitalisation may have improved some aspects of the treatment that was provided. I'm also comfortable with the COVID-19 being the principal cause of death and ischemic, the emphasis being placed on the COVID-19 and less emphasis being placed on ischemic heart disease.
Can I just ask a follow-up question here, just to clarify? Professor French, you've understood what's just fallen from your colleagues as being a broad area of agreement that hospitalisation would probably not have made a difference to outcome. Professor Cole, is that your opinion? Or are you saying that hospitalisation may have affected outcome?
Look, it's very hard to know. She was 92 and she did have multiple comorbidities, but whether better supportive care in terms of food, fluids, monitoring her pain, treating her pain, may have made a difference. It was her wish to have all that happen.
Okay. Does anyone wish to say anything further? For the record, that was Professor Consimbos indicating his agreement with what just fell from Professor Curl. On the 11th of May, Margaret Sullivan passed away. She was 71 years of age at the time. Can I ask you, first of all, about the cause of Margaret's passing?
The COVID-19 infection, significant contribution by her dementia.
Thank you. Professor Curl?
COVID-19 infection yes, with her dementia with Lewy bodies contributing significantly to that.
And Professor French.
In my report, I've had the recent COVID-19 infection as a contributory factor and complications related to a Lewy body dementia as the sort of primary factor in the cause of death. But again, I'm comfortable with the emphasis being reversed, as my colleagues have suggested.
Placed on the COVID factor. Can we then move to the follow-up issues? First of all, from you, Professor Katsimbos.
So the main thing I noted here was there weren't any other significant comorbidities in the documentation. She was diagnosed on the 17th of April, so in the second wave of testing, if you like, raising the possibility that better infection control right at the start may have made a difference. There was a lot of well, the next thing I'd say is she really didn't require a lot of respiratory support until the 8th of May. So things were fairly stable for a long time. And in fact, there was a lot of toing and froing in terms of whether she'd recovered from COVID or hadn't recovered. And that testing and that conversation with the next of kin was particularly difficult because there were mixed messages occurring. On the balance of probabilities, I don't think the outcome would have been different, but I do think the communication with the next of kin could have been better, particularly in terms of how the end of life period progressed.
In your report, page 69, point 3, you say supportive care plan became somewhat confused in setting of health stabilisation. What exactly were you referring to there?
The mixed messaging. Because she'd returned a negative test, it was not clear what the focus of the managing team was, and how that was related to the family confused the family. They felt that COVID was no longer in the picture, so we're stabilising. If the COVID-19 infection was still in play, then some sort of supportive care and monitoring, and maybe extra intervention may have been relevant.
I have to then ask you about the next part of that part of your report. It says this: negative follow-up COVID test on 6 May suggesting possible recovery from COVID-19 with cause for deterioration and death over next 5 days not completely clear.
Yeah, so again, this it touches on the previous case as well. So we had a negative test, but there was still a progression, and it was just not clear what was happening. Was the negative test a false negative test, and the COVID was still in the picture, particularly in her lungs, or had something else happened, or had had something else happen. It just was not clear to me.
Okay. Professor Curl.
Mrs. Sullivan's, certainly her dementia with Lewy bodies contributed significantly. There was a lot of confusion, as has already been noted, whether she was terminal. Her husband was told she was terminal on the 1st, and medications, all medications other than crisis medications, were ceased. So this lady didn't really have observations or medications or fluids for probably 7 days, and I suspect that may well have contributed. Her husband asks why fluids and medications had been ceased, because he hadn't been consulted. And I think he was concerned that his wife had stated she did want interventions. But and then at the end, he was told by Dr. Brownlee 2 days before she died that she was coming out of the end. I'm not quite sure what that meant, but clearly there was confusion and mixed messaging. And it would have all been very difficult for the family.
If Mrs. Sullivan had come into hospital, do you think that her treatment, are you able to say whether her treatment would have followed a different course?
Oh, I suspect her treatment would definitely have followed a different course, in that she would have been kept hydrated and fed and as much as possible, and her any symptoms treated. I think that's fairly important. She did receive pressure area care and comfort care, but she wasn't given fluids. So I'm not sure what comfort care is if you're not giving someone fluids. So I think there would have been more treatment had she come into hospital, and she was certainly one, despite her significant dementia, who I think may well have benefited from her from coming into hospital. Other than her dementia, she was relatively healthy.
I just missed a word that you said there, Professor. You said she's one who may well benefited. Is that what you said?
Benefited from being transferred to hospital early on, because she wasn't receiving a lot of care or assistance in that last, if you like, 10 days of her life, from the 1st of May to the 11th of May. And I think that could have made a difference in terms of receiving fluids and nutrition.
Right. Are you able to put a probability on it, or is it we're talking in the realm of possibilities and you can't say anything further?
It's hard to say anything further, other than she was relatively healthy apart from her dementia with Lewy bodies. And where if she had been given adequate food and fluids in particular, it may have made a difference. It was more the level of care that she would have received in hospital would have been greater than she was receiving in Newmarch House at that time.
Thank you. Professor French.
I've got nothing further to add to what Professor Curl and Professor Consimbos have said.
Right. Thank you. Professor
I'd just like to reflect a little bit more on Professor Curl's comments and my comments too. I think my comment, with cause for deterioration and death over the next 5 days, is not completely clear. I think it's important then to if you put it in the context of what we've just heard from Professor Curl and the fact that there were negative tests. You know, I put it down to perhaps they were false negatives and she's progressed and we just didn't pick it up in the documentation. The other almost equal likely possibility is she has deteriorated from a whole lot of things that haven't been done, because the negative test may be significant here. It may not be a false negative. So I think I would, on reflection, I'm almost at equipoise with this now. And I agree with Professor Curl, more could definitely have been done in terms of supportive care. And it's almost a 50-50 call whether it would have changed the final outcome, but definitely it would have changed two things, which would have been a more comfortable, supported person and a better death if it was to go to that, with the family being properly involved.
Professor French, is there anything further that you want to add, having heard what Professor Consimbos has just said after hearing from Professor Curl?
I guess they're talking about areas of management of persons. It's outside my area of expertise, and I'm comfortable deferring to their comments.
Thank you. The last resident to pass away was Alice Bacon. She was 93 years of age. She passed away on the 19th of May. Now, first of all, can I ask about Alice's cause of death, please?
COVID-19 infection, significantly contributed to by ischemic heart disease.
Professor Curl?
COVID-19 infection on the background of ischemic heart disease and asthma.
And Professor French?
As you see in my report, I had the emphasis placed on her underlying medical conditions and recent COVID-19 being a contributing factor. The principal basis for that was the 3 negative COVID tests returned on the 15th, 16th and the 20th of May, which must have been come back off the day. So, and the duration of her illness as well. But again, it's a matter of emphasis. So it's sort of a bit of a difficult. I found some of these cases quite difficult to actually know exactly to be able which way to place the emphasis. So, and it could be a decision either way. So, I'm comfortable again if my colleagues on balance feel that it was more likely related that COVID-19 infection was the most likely cause of death, and the other and underlying medical conditions the secondary causes. I'm comfortable with that being the cause of death.
This is a complex case. You'll remember from the evidence that there was a moment in the course of treatment where comments were made by various people that she seemed to be improving.
Yes.
There was an intervention by Dr. Branley, but there was a conflicting approach at one point taken by a palliative care specialist who cancelled, for example, fluids and medication after they'd been ordered by a different doctor. Just to put you in the context. Can I first of all turn to Professor Katsimbos in terms of the follow-up issues here?
So significant comorbidities were asthma and airways disease, and again, I make the point here that her diagnosis was on the 23rd of April, having several negative tests beforehand, 3 beforehand. So again, well into the propagated wave of infections, and so the question is, could that have been prevented? Interestingly, she then has several positive tests and then 2 negative tests. So, and that leads into the discussion about whether she'd recovered or not, and were we at where were we with what we were doing here? Looking at the notes, it's quite clear there was a respiratory infection component. There was some confusion whether some of her respiratory symptoms were due to her asthma or due to respiratory infection. She did receive treatment for her asthma as well. There was some question related to whether she would benefit from extra fluids or not. She had been on Lasix. There was some evidence that she might have had some crackles in the lung, which sometimes are related to infection and sometimes related to fluid if the heart isn't working well, and so she was given diuretics. So there was a whole lot of things pulling and pushing in different directions. So medical assessment here is critical. And so in that setting, the medical assessment that did occur and the way that interacted with the next of kin particularly was perhaps a little bit difficult because the messaging became quite confused in some ways, whether the patient had COVID and had fully recovered or whether there was ongoing COVID. And in the end, when the situation had progressed and she needed crisis medications, they were started relatively late because of this confusion. And so I found this comment amazing, and I will repeat it if I may. The active supportive care plan that became somewhat confused in the setting of late clinical deterioration and resulted in a relatively delayed use of crisis medications and an appropriate comfort plan for the patient, much to the dismay of the next of kin, who complained that they felt, in inverted commas, as if they were on a roller coaster, close inverted commas, only to be told by the doctor present, we are as well. I just found that a very telling summary of the situation that we'd gotten to then.
And is that in terms of lack of consistency or continuity in medical care?
I think so. There was a specific thing about the medical care for this specific patients. I think it goes to the mindset of the medical staff and perhaps the nursing staff. They were struggling. And so it's very hard to look after people when you're struggling as well.
Yeah.
And I think it really shows up in this case particularly.
Okay. In terms of whether an early intervention, hospitalisation could have made a difference here?
Yeah, because this patient, so the big point was infection was late, so that could have been potentially prevented. The second point is because of the toing and froing in terms of what was actually happening, I think hospital transfer may have helped here. I just can't remember what her she didn't have an advanced care plan, but somewhere along the line there was a not for resuscitation decision. But in terms of the assessment and a fuller clinical assessment, I think that would have been helped, and also in terms of the appropriate use of crisis medications, so they were given at the right time.
I think the evidence suggests here that there was an undated advanced care plan which indicated not for hospitalisation except for comfort. Yes. Then the advanced care plan was updated on the 17th of April 2020. But that didn't change, did it? And it was that option did not change. In other words, comfort care only.
Yeah, I had no advanced care plan, but not for hospital transfer, for treatment in nursing home. Yeah.
Just before I move on to Professor Curl, can I just bring one other matter to your attention? As far as we're aware, this is the only resident who was delivered morphine by way of a syringe driver. Is there anything you wish to say about that particular circumstance?
It's an effective way to do it. I think it's more, for me, it's more about the starting it at the right time.
And do you want to elaborate on that in terms of when the right time was?
I'm just trying to remember here. Because of the confusion whether the patient recovered from COVID and then the late clinical deterioration not being clear, it wasn't clear what was going on for me and probably for the people looking after this patient. So it seemed that the crisis medications were delayed. There was a delay. So there was a period where she was deteriorating. She was deteriorating and suffering without the medications being given.
Professor Curl.
Yeah, I'd like to continue on with the theme that Professor Kotsimbos started in terms of her quite complex management issues in terms of being given a diuretic, and then she was written up for or ordered subcutaneous fluids by Dr. Sharma. These were ceased by the palliative care physician. These were then restarted by Dr. Branley. And you could see the incredible confusion between the medical team just with where this lady was going. And I feel had she been in hospital from earlier, that would have been dealt with hopefully a lot more clearly, and she may well have come out, despite being 93, come through this with support. I acknowledge that there appeared to be an advanced care plan saying treat her at Newmarch House rather than go to hospital. But she'd been very involved and active up till the time of the COVID lockdown. So she was quite independent prior to this happening. My other comments were, that she was told she'd be better off in Newmarch House than in hospital, where she would have to share a 4-bed ward. I'm not sure that sharing a 4-bed ward is the issue here. It's really that she has adequate nursing and medical care and that the various problems are addressed. And that the team would work together rather than, if you like, contradicting each other's orders, as clearly happened.
Just while you're addressing that issue of the 4-bed ward not being an issue, in the event that she was placed in a 4-bed ward and that she was there with other COVID positive patients as part of a special part of the hospital designated for taking COVID positive patients, would that cause any difficulties or problems from your perspective?
It's certainly what happened in other hospitals where patients who were COVID positive and still do share 2 or in some situations 4-bed wards. So the important thing is they were all known to be COVID positive and would be receiving appropriate care.
And was the fact that such patients are placed in a 4-bed ward, did that impede proper care being provided in the hospital, as far as you're aware?
As far as I'm aware, no. It was the care, the nursing and medical care that they received that was important. Certainly from personal experience, we have our whole ward has negative pressure. So we actually have a ward rather than just having single rooms, negative pressure rooms. So there is that possibility. And I'm not sure what the situation was at Nepean Hospital in terms of their COVID ward. I'm sorry.
Well, there's been evidence on it, and it's along these lines. There was a ward set aside. That ward had 2 pressure rooms, 4, likely to be the case that there were 4 two pressure rooms that were single rooms. So 4 singles. 2 pressure rooms, 4 single rooms, and then just excuse me, I'm just going to have to get this completely correct.
30. Yeah. 4 single.
Yeah, that's right.
And plus 2 negative pressure.
Yeah, that's right. Okay. A designated ward set aside. There were 2 negative pressure rooms, 4 single rooms. The remaining rooms were 4-bed rooms. And the total number of beds in the ward were somewhere between 28 and 30 beds. There's an issue about whether you count the 2 negative pressure rooms in that number. There's an uncertainty in the evidence about that. That's the evidence as it stands at the moment. And then there was the capacity to spill over into other wards if that particular ward became overburdened. So does that architecture, that layout, suggest, Professor Curl, from your perspective, any particular problems in terms of hospitalising someone like Ms. Bacon?
Just that, she may be confused by being put there, but it wasn't clear that she had actually a degree of dementia. But moving any older person to a different environment is going to be difficult. But she'd already been moved once, including into a room that had belonged to a friend of hers who died, obviously prior to the move. So I still feel that had she been transferred to hospital, whether it was a 2-bed ward or a 4-bed ward, she would have received the level of care that may have made a difference. And I think that's what's important. If everyone in the ward has COVID, which is certainly as it is in our COVID ward, then the fact that it's a 2-bed or a 4-bed probably isn't going to make a lot of difference. It's the care that she would receive. However, this is not my area. I'm just speaking about my experience observing. I'd be much more interested in Professor Kotsimbas's comments about this.
Okay. Before I go to Professor French, Professor Kotsimbas, do you want to add anything further?
I think that's right. I think she already had COVID, so there's not a risk to her necessarily of getting COVID. And I think that the key thing is how much extra care she would have got, and we have to reference the care she wasn't getting and perhaps she was needing in terms of those mixed assessments and the mixed messaging. So there was a potential for an improved situation, even given that structural setup. And it's never just the structural setup, it's how it's operationalised. It's the level of PPE, it's the level of education in the nursing staff, the level of skill in the nursing staff. That's also just as important as if you like, the geographical structural setup. And that's likely to have been a lot better in that environment.
The family in this position had indicated that they did not want Mrs. Bacon to be ventilated. Does that impact on your opinion, Professor Curl, or yours, Professor Kotsimbas, in any way? that ventilation was not being indicated or requested as a form of treatment here.
So I'm happy to pick that up.
Yeah.
I think certainly so she won't be ventilated, but there's a lot more we can do below that level of support, and that's the important thing. And I find this quite an important nuance that you can make something sound very easy by saying, oh, well, you won't be ventilated, or hospital transfer isn't going to help you because we can't fix what's going on. But it's all predicated on what's going on and what the understanding is of what's reversible or not.
And just to follow up on that, because I may not have been as clear as I should have been reading this note that was just passed to me, but it's the point that the family only said
That's right. So,
no to ventilation. They didn't say no to other forms of intervention.
That's right. And that's really what I was trying to get to.
Yeah.
Thank you for pointing it out. But I also think it's relevant in terms of hospital transfer. Often the assumption is there's a lot of these advanced care plans are tick box exercises. Do you want hospital transfer? And when the discussion is happening, and hopefully there is a discussion, sometimes there isn't, it's in the setting of, well, you don't want to go to hospital, you don't want to be transferred if there's nothing they can do. But so that's how the informed consent gets played out. But sometimes there is something they can do, and so we've ticked a box that says not for hospital transfer, but we've left out that other nuancing qualifier, which is, of course, I don't want to be transferred if there's nothing that can be done. But if it was said to them that there is something that can be done, perhaps it would not be that box that was ticked.
Right. Can I just relate to you some evidence that was given yesterday by Dr. Dharma Ratnam, who's one of the general practitioners who had an important role to play in terms of having those advanced care discussions. And he gave evidence that, in effect, that he understood that hospital transfer was not an option at that stage. That apart from intubation, CPR and life support, all other treatment that could be given was available at the aged care facility, and that he was informing people accordingly. He was also informed, before he had these conversations, that no hospital transfer or life support would be offered. So that's one of the doctors who's going in and having the conversations. That was his understanding.
So hence my point. And then can you imagine the person hearing that is likely to say, well, I don't want to be transferred. So the way the whole situation is framed almost begs the response. And I think we've talked a lot today about a whole lot of supportive care things that weren't included in that, particularly in someone where things weren't so clear.
I'm going to come back to the consent issue, and I've got to move towards completing my part of the questioning. But Professor French, what do you wish to say, having heard?
Yes, I completely agree with my colleagues, in particular with regard to the changing medical treatment that Mrs. Bacon experienced, and the consequences of that, not just for her, but also for her family as well, in terms of the messaging that would have been provided at the time. And I also agree when the provision of information to patients' families and regarding how that information is framed, and if the context is that hospitals can offer a lot more than intensive care. Intensive cares are a relatively small part of the hospitals, and there are many effective treatments that may be of benefit to persons provided in the general ward. In fact, they're probably more provided in the general ward than in the ICU.
Does anyone wish to say anything further about the case of Ms. Bacon before I go to some of the final and general questions not related to specific individuals?
Very quickly, because you did raise it, the syringe driver, I just have looked at my notes here. That was commenced at the crisis medications were commenced at the request of the family. And with a syringe driver, usually we can escalate the morphine dose a bit quicker. It still took 3 days of potential discomfort for the end to come here. So there was a lot of distress here.
Can I first ask each of you about this issue? I want you to assume, for the purpose of this question, that there has been evidence in this inquest that during the first period of the outbreak, the first week to 10 days or so, that there were significant staffing shortages during that period. And in particular, the 18th of April and the 20th of April have been singled out as days involving more acute staff shortages. For example, on one of those days, the 20th of April, Dr. Brandley, who was on site at the hospital at that time, had to attend to the personal care needs of patients because there just weren't sufficient staff on the ground. I also want you to assume that there is evidence that there was insufficient medical equipment at the home, particularly in the early phase. A nurse named Nurse Giles, a senior nurse who came in to help manage the facility on the 17th of April, noted that there were insufficient machines to monitor blood pressure, temperature and oxygen saturation. They were ordered on the 19th, they arrived on the 24th. Another nurse named Nurse Bestrin has given evidence about a lack of glucometers for diabetes. There was evidence that the capacity for the provision of fluids was not present in the first instance, and that a device had to be brought into the home. There is evidence from families that refer to occasions when personal care, food and sometimes medication was not provided in a timely manner. Now, I've gone through a number of factual assumptions there. It'll be a matter for His Honour to ultimately find whether those matters are made out. But can you just assume those matters for the purpose of the question? What were the likely impacts of those types of circumstances on the level of care provided at the home?
I think my broad comment would be, it would be an unreal expectation that Newmarch House could provide the level of care it purported to be able to provide to these patients.
Professor Pearl?
I agree totally. It shows, that lack of equipment shows that however you look at it, Newmarch House was not a hospital and could not provide the hospital in the home level of care that even a very basic level of care that would be required. But we have to remember Newmarch House is these people's home, and it was never designed to be a healthcare facility. So the lack of equipment is not surprising. However, I know other residential care facilities did realise early on in February of 2020 that this might occur, and there was quite a bit of ordering of equipment. So clearly some organisations did anticipate there might be issues. That wasn't the situation here. And, in terms of infection control, you do need to have individual pieces of equipment for a lot of these tasks.
I agree. If assuming that the number of staff was insufficient and the amount of equipment available was insufficient, and hearing that other staff, including medical staff, were having to provide personal care to patients, it seems extremely unlikely that the environment at Newmarch House would be considered functionally equivalent to a general hospital ward.
Was it ever realistic to expect that Newmarch House could operate as a surrogate hospital ward in the context of a significant outbreak of COVID-19 amongst the residents? Professor Consimbos?
Well, I can understand why the initial position was that it might have been, but but that would have required only a few cases. But once there were a lot of cases, once all the other problems that you've delineated became obvious, once the staff, because this was an environment of a lot of fear, the staff had fear, and once staff infections occurred, once the fear in the staff became a problem in itself, once all those things compounded, I think it would have become very obvious that even though you might have wished it to be the case and you might have started that way, it should have been quite obvious relatively quickly that was not going to be something that could be a workable solution to the problem at hand. And it wasn't just the staff shortages. It was so the staff getting sick and so on. It was the fact that they needed more staff. They couldn't get staff. So the quality of the staff changed as well. So it really became a compounding problem, and it became more and more obvious.
Just before I go to your colleagues, in your report, page 10, paragraph 13, you say this: the operational difficulties encountered as the cluster outbreak under investigation evolved from mid-April to just over mid-May made it increasingly necessary to have a rethink regarding how the situation at Newmarch House could have been improved. In particular, consideration could have been given to what potential alternative models of care may have looked like, given that both the realities of what was occurring and the various resource constraints present. What is that rethink that you think should have occurred? What are the alternative models of care?
The alternative would have been to transfer them to a specified place in a hospital that had the capacity and the resource and the skill set to deal with it, and that would have meant that a lot of the things we talked about, particularly in terms of proper supportive care, proper assessment, proper up-down titration of needs, proper end-of-life care, proper communication, would have occurred with a staff that perhaps were more capable to carry out those duties. And at the same time, if it was done early enough, it would have limited the ongoing infection wave that was propagating within the home. So the people that were negative would stay negative. So that's how I saw it.
Professor Curl?
Yeah, hospital in the home, if you're doing it within a residential aged care facility, is usually designed for single patients with conditions such requiring intravenous therapy of some sort, such as cellulitis, severe infection, clots, deep venous thrombosis, pneumonia perhaps. And it's usually one or two patients within the facility. It was not designed for contagious respiratory diseases, to quote a colleague. And I think it's for non-critical patients, it's for stable patients, and for the numbers would be one or two, not a whole, not a whole or even half a residential care facility. So I think, unfortunately, it was doomed to failure from the start.
Having heard what Professor Katsimbos said, that a moment arrived when there should have been a rethink, and he's indicated that the alternative model that should have been pursued was hospitalisation. Is that a view with which you agree or disagree?
I totally agree.
Professor French?
Professors Curl and Katsimbos are expert in this area, and I accept their opinions.
I mean, by the time people come to you at the ICU unit, of course, things are very dire indeed. And you tend to be treating people who have the capacity to deal with ventilation, for example, those sorts of more invasive and burdensome treatment options. Can I ask, were both Professors Katsimbos and French provided with Professor Curl's written report, as part of the preparation of your opinions? In that report, you may recall that Professor Curl provided a detailed analysis or list of factors, paragraph 165 on page 22, as to why the hospital in the home model was unable to provide a hospital level of care for the Newmarch House residents.
So I remember that.
Okay.
I was in agreement, but I do feel I should check it again.
Yeah, if you can just quickly cast your eye over it. It's page 22 to page 23, paragraph 165. I might ask that it be put up if we can, in the event that you're having difficulty turning it up.
No.
Just tell me when you've read that.
Paragraph 165.
Yes, please. And have you read that first page?
Yes, I have.
Okay, could we go to this page 23, please, just for the balance of the paragraph?
I was happy with all that.
Okay, is there anything you'd wish to add to it?
And not,
Anything you disagree with?
no, I don't disagree with anything. I think I had a similar paragraph in my report.
Yes.
I'm very happy with that.
No, I'm happy to agree and accept Professor Curl's opinion.
Thank you. What are the disadvantages with transferring COVID-positive patients from the Newmarch House contingent to hospital? What were the disadvantages in taking that approach?
Well, would you like me to start?
Yes.
So the big disadvantage is you're dislocating someone from what is effectively their home and from the people that know them. But that has to be weighed up against the advantages, of course. The other disadvantage is potentially, and this depends on the mindset of the person making the decision, that you may be taking infected people and putting him into another an infectious risk situation, particularly in a more acute hospital setting where there may be significant implications if the infection control measures aren't appropriate. But that's quite speculative.
Just before I turn to your colleagues, can I ask you this? In respect of the first of those factors, which is effectively taking an elderly person out of their familiar environment, is it a relevant consideration that because of what was happening at Newmarch House, lockdown, being locked in their rooms, not being able to socialise, disruption of the normal pattern of activities, staff coming in full PPE gear, which they wouldn't have been familiar with, cessation of family visits or limitation of family visits to window visits, disruption in food, medication, all of those circumstances. Is that something that would have made the experience of Newmarch House less familiar for those individuals?
That's an excellent point, actually, and I think framing it, we tend to frame it in terms of it's their home and the care is all over there. But as you have rightly pointed out just then, it's no longer really their home. There's a lot of negatives in staying there, potentially. So I think that will obviously can be better assessed and nuanced for each individual case. But as a general comment, things have changed. It's not a comfortable home anymore.
And then the second factor that you went to, was infection control, effectively, and the risks of transmission by moving people out of the home. What weighting should be given to that factor in this type of decision-making process,
I think,
given that there was a COVID ward at Nepean Hospital that had been established in anticipation of this outbreak?
so I don't think it should be as great as perhaps the weight it was given, because the situation in a hospital setting is such that you are better resourced, better prepared, better able to deal with that very problem. And that has immediate benefits for the community at large if you take the hospital's duties to everybody.
The third matter that I wish to put to you is this. Is it the case that leaving elderly patients in a situation of isolation within the home for a lengthy period of time because of the lockdown condition, that itself can lead to deconditioning and adverse outcomes?
Certainly, but I think equally the isolation procedures at the hospital would have a similar sort of.
So that's a neutral factor.
Potentially, but there may have been more care to risk mitigate that in a setting that was better resourced and better aware.
Which
The
setting?
hospital setting.
Professor Curl, there have been 3 matters that have been dealt with there. Are you able to respond?
Yes, in terms of the dislocation from their environment, they already were not allowed to move out into the living areas. So they'd lost a part of their home, if you like. A number of them were moved anyway within the facility in order to try and cohort patients. So that certainly happened. And I would have to say, I think the leaving of a familiar environment is far outweighed by the benefits of being in a much more supportive care situation. The issue of infection control is really significant. I think it's perhaps not given enough emphasis, but in hospitals, the infection control clearly is at a higher level than it would have been in residential aged care. And I can say that from personal observation as well. The staff were changing, so the fact that there were, you were leaving your familiar staff, something like 80% of the staff, 87% of the staff at Newmarch House were furloughed or were off for a while. So they're losing that familiarity anyway. And as already mentioned, they've lost their family, the family visits and that sort of input. In terms of deconditioning when they were locked in their rooms, we certainly heard from a number of family members about the distress that was caused when they spoke to their family members in Newmarch House who weren't getting showered or the beds changed or getting their food. Hopefully that would not have happened in hospital. So there's those sorts of factors that you have to throw into the mix as well. I also know that from the very start, certainly in my hospital, I'm aware it happened in others, we had physiotherapists who volunteered to do some exercise with those people in the COVID wards that could do some exercise within their rooms, so they didn't get the deconditioning that clearly happens when you can't move further than around your bed. And I think that's another factor that needs to be put into perspective. I think there was some physiotherapy in Newmarch House, but it was minimal. And there were just so many disadvantages to staying there that I think the benefits of moving to hospital do outweigh the risks.
Professor French?
I think your questions relate to the expertise held by Professors
Yes.
Curl and Kotzimbas, so I accept your opinion.
Thank you. Can I move now to the issue of consent, advanced care plans, advanced care directives? Professor Curl, in your report, you've differentiated or distinguished between the 2 types of discussion or document. Can you just quickly review that in the event that the nomenclature is different from what's used in Victoria?
Yes, certainly. So in New South Wales, the terminology advanced care plan, that is a advanced care directive, that is a directive made in advance, is made by a person when they are of sound mind. So while they're still capable of saying what they want at the end of life, or what they want when they are no longer able to say what it is they want. An advanced care plan and an advanced care directive in New South Wales is legally binding. An advanced care plan is a statement usually written by a family member, but occasionally by a staff member at a residential care facility, that sets out what the person might want in the future and hopefully reflects their plan, but it is not legally binding for as is an advanced care directive.
Now, can I ask this question, please? Given the evidence that's been given by the panel, the conclave, about the benefits of hospitalisation, given the evidence that you've given about perhaps the need to rethink matters as conditions have deteriorated at a point in time in the home, did the process of obtaining advanced care, withdraw that, did the discussions concerning advanced care require consideration of the advantages of going to hospital? Is that something that should have been raised as part of those discussions?
I think
You want to start, Professor Cole?
Look, clearly you're looking at informed consent, and so the person has to be given all the options. I don't think that occurred in a lot of these cases, and therefore it wasn't true informed consent. So the person wasn't making a decision, either the person themselves, the resident, or more often their person responsible, who can make medical decisions for another person. If they weren't given all the information, then it's simply not informed consent. And I would add one thing. I've been very involved in the development of advanced care plans, advanced care directives, and encouraging their use. And I would note that since the start of the COVID pandemic, a lot of my patients in the early stages of dementia who have made advanced care directives have actually changed them, because they are very aware that by saying they want to stay at home or stay in the residential care facility, they are putting their co-residents at risk and their carers at risk. And they changed them to
do you mean risk of infection from COVID? Did you mean risk of infection? Sorry, did you mean risk of infection from COVID?
From COVID, yes. If they had COVID, they wished to be transferred to hospital so that that is the resident, would not give other residents or carers the infection. So it had been thought through quite a bit. And I think we have to remember that a lot of advanced care directives were made prior to the pandemic, and that does need to be taken into account. I was quite surprised at the large number of people who have changed their advanced care directives, or families who have changed their advanced care plans, knowing that's what their family member would want.
I mean, in this case, what would you have liked to have seen discussed with the patients or their families, their relatives, to allow them to give informed consent to the treatment model that was pursued here? What information do you think should have been provided?
I think the information should have been correct. To say that a person will receive exactly the same care in Newmarch House as they would receive in the Nepean Hospital is clearly not correct. And I think that they should have been given the options and be told that, the difference. I don't think they were given that opportunity.
Dr. Consimbos?
I completely agree with Professor Curl. The key point is the informed consent, and the informed consent, the key point there is both the information that's transferred and the consent, and the information that is discussed has to relate to the event that's about to occur. So when an advanced care plan is made generally, that generally holds, but when the specific situation is so different to what was perhaps imagined when the discussion occurred, that plan should be revised, and the right information that covers all the various possibilities, both in terms of what can happen at the home and what can happen at the hospital, needs to be conveyed so true informed consent can occur.
Evidence was given by one doctor in this inquest to this effect. Question was asked, so you say even if a family member requests that there is a transfer to a hospital for ventilation, your evidence is that ultimately, whether or not the patient is transferred, ultimately that decision is to be made by the treating team and not the family. And the answer given was yes. But that answer seemed to suggest that ultimately, even if the families or the resident expressed wishes that they wished to be transferred to hospital, for example, for ventilation, that wish could be overridden by the doctor on site. Is that a correct approach?
I think that the first thing that should happen is a proper discussion, because the need for a better understanding of what may or may not occur may help sort of navigate that situation. For instance, the request for ventilation may be in the mistaken belief that outcomes are going to change. But if a very careful, compassionate discussion about, no, the outcomes are not likely to change if that degree of support is to occur, and indeed there may be associated suffering, you would hope that that rational discussion would lead to perhaps a different request. Equally, a more rational discussion about what can be given that may be acceptable in the hospital may lead to a situation where hospital transfer would be acceptable.
Yeah, I think that the statement you just read links two issues that are related but also separate. That the decision for intubation and mechanical ventilation and the decision to go to hospital. It is correct that medical practitioners, certainly in the jurisdiction of Victoria, are only they provide medical treatment that they believe is medically indicated, and there's no compulsion to provide treatment that they don't believe is medically indicated or in the best interests of the patient. And for many of these residents, it may well have been, from what you've heard, given their comorbidity and frailty, that intubation and mechanical ventilation was not going to be medically indicated. However, that does not mean that many of the other treatments and interventions that can be provided in a general ward would not have been beneficial for those persons. So I think they've linked two things that perhaps need to be separated.
Yes.
The need, what you're really talking about, the need for transfer to hospital. Yes, being mechanically ventilated requires you to be in hospital, but you don't need to be mechanically ventilated to be in hospital.
Yes. Is there anything you wish to add or respond to in respect of what Professors Curl first in that lengthy answer, and then Professor Katsimbos said about the basic requirements of informed consent here?
No, I concur with what they've said.
I'm about to complete.
Sorry, Jawad, just to save time, there's been a lot of evidence about discussions, but no elucidation as to who should be providing the information, just to save time, as to who should be providing the information about the medical option.
And you've heard that question on who is responsible for providing this information and having this discussion. And I'm directing you to a particular setting, which is patients receiving care under a hybrid hospital in the home VACS model in a residential aged care facility.
I'd be happy for Professor Curl to start.
Gee, thanks. Look, clearly it's going to be in VACS, in a virtual aged care service, it would be the geriatrician or the nurse practitioner speaking with the resident or the family member about the options and making very clear the advantages and disadvantages of them. So it would be the healthcare staff doing that.
So I would have gone more generic. I accept that. I think I would have gone a little bit more generically. I think it's the person that is most responsible for the patient and is most aware of all the options.
Yeah, I would concur. Person most responsible who is able to give the accurate information required.
All right. Can I just ask this follow-up question? From your review of the notes here, the clinical records, which you've all given evidence about are suboptimal. I think that's fair, isn't it? Were you able to discern who had clinical responsibility? in terms of these patients from those records?
Not reliably.
Professor
Not
Contempt?
reliably, and that's part of the problem, I think. There was no clear chain in command, of command, and potentially, I would even go one step further, the people that perhaps had the biggest appreciation of all the options weren't necessarily the people having these discussions.
Professor Curl?
Yeah, I'd agree. I think the last case we discussed illustrated very clearly that no one was in charge, with 3 different specialists doing 3 different things. The GPs were excluded from care, and I think that's a real issue because with hospital in the home, they are no longer considered part of the medical team and they're not allowed to bill for visiting patients. I would note in Dorothy Henderson, the outbreak, there was a GP who actually worked in the facility and did not really leave the facility. So there was very clearly someone in charge, and they would have been the person to speak with family members about what would happen because they would understand, I guess, all the ramifications.
2 last questions. First of all, this unfortunate episode seems to involve, at one level, a tension between, on the one hand, the rights of elderly patients to receive the level of care, and in particular medical care, that they're entitled to, and on the other hand, what might be described as public health concerns, such as risk of spread of infection. Can I ask you to comment on whether there is in fact such a tension and how it impacted on the experience at Newmarch House? Professor Consimbos?
I think it's a false tension. I think they are both important dimensions of what we're trying to do here.
Yes.
And I think a more imaginative approach can see both happening as an and rather than an or. What I mean by that, the rights of the elderly people can be upheld, and at the same time we can limit spread in the nursing home and in the community.
And when you say in the community, does that include the possibility of having to transfer patients to hospital?
Yeah, because I think there are ways to risk mitigate that are very appropriate and very well rehearsed.
Professor Curl?
I agree completely with Professor Katsimbos.
Professor French?
Yes, I agree that there is a tension. I think we also just need to reflect though in April and May 2020, there was a lot unknown about COVID, a lot less known than there is known now.
Yes.
And a lot of uncertainty within the broader community, the medical community. Everyone was very concerned about this illness, and some of that underlying anxiety and fear influenced decision-making. In hindsight, it's clear it's influenced decision-making at the time.
The influence
was the fear and anxiety that people were feeling regarding this new infectious diseases, and particularly seeing what was occurring overseas at the time as well.
Does that mean that the infection containment aspect of the equation was given an increased weighting?
It may have, yes. That may have been, in my opinion, that may have been a contributing factor to that.
But excuse me, but only in one aspect.
Only one aspect.
Not in the other aspect,
Yeah.
which is the nursing home spread.
That's right, spread within the nursing homes. Finally, can I just give you each the opportunity to make whatever final comments that you wish to make about this issue, about what happened at Newmarch, about the evidence that's been given today in the conclave?
I'm very comfortable with how the discussion has gone. I'm very comfortable reviewing my report and hearing from my colleagues and also the questioning that's occurred. There was one thing that I do want to add to the commentary perhaps, and the one thing is the amount of the pressure for advanced care plans to be made on the spot that become then a self-fulfilling prophecy, which almost builds on that earlier discussion of the crisis meds being chartered as soon as a diagnosis is made. And I think we shouldn't ignore that because that colours a lot of thinking.
Thank you, Professor. Professor Curl?
Look, I was going to say something very similar. Advanced care directives and advanced care plans should not happen in a crisis situation. It is just not the right thing. And I think we do need to watch that very carefully, because things might have been different if they had been observed and people understood what they actually meant.
How was that situation avoidable? I mean, just accept here that in many cases, advanced care plans had been completed at the home as part of the admission process, for example. They might have gone back some years, but there were documents in place. How was it avoidable that there would be an updated or updating discussion in the context of an outbreak of the kind that happened at Newmarch? Doesn't it follow from the evidence that's been given earlier about the need to provide specific information about the risks and benefits of either course? Doesn't that mean there has to be this type of conversation in the grip of a crisis?
Certainly, but not just when someone tests positive. So I'm aware of other organisations where this was done, months before. Would you like to rethink your advanced care directive or your advanced care plan? So I just think there are probably better ways to do it, but it is a very fraught area.
So what you're indicating there, Professor Curl, is that from the time that there was a COVID outbreak in Australia and the problem was looming, that was the time to address that issue, rather than waiting for the outbreak to hit the facility.
Yeah, a lot of people rethought their advanced care plans well before there was an outbreak in either their facility or in the community generally. So people were thinking about this, particularly older people. And I know GPs were also talking to their family. Look, the other thing I wanted to add was the lack of GP input into the whole management of the pandemic at Newmarch House. GPs weren't or did not appear to be consulted yet. They were the ones that knew the residents really well. And I think that is an area that involvement of the GP needs to be emphasised in any future management of COVID outbreaks.
Professor Kotsimbos, just before I go to Professor
Very
French,
quickly,
you had your hand up.
On the point of we're getting stuck on labels here. An advanced care plan directive is most useful when you have a very clear prediction of what is likely to happen, and you may lose your voice when it's happening, and so you state it before it happens. When the situation changes, clearly that prediction doesn't hold, and the advanced care plan in that setting isn't as relevant, and it should always inform goals of care and resuscitation plans in the setting of any event, but particularly in the setting of an event that wasn't predictable.
Professor French.
Yeah, I firstly just wanted to acknowledge that it was very challenging reading the stories of these 19 persons, and I thought so with obviously them and their families, but also the staff who cared for them at the time in what was clearly very difficult circumstances.
Thank you. They're my questions, Your Honour.
Thank you. Professors, I just wanted to briefly revisit the discussion regarding one of the residents, and that concerns Mr. Victor Stone. If I could start first with you, Professor French. In your evidence in your report, you referred to the possibility that Mr. Stone's deterioration may have been due to intracranial pathology as a result of a mechanical fall on the 22nd of April 2020. And what I wanted to ask was whether, by reference to the possibility of some intracranial pathology, you're speaking about the possibility of a traumatic injury?
Yes, I was. Yes, traumatic brain injury specifically.
I see. And does that mean that on the evidence available, in your opinion, it's possible or not to exclude the cause of Mr. Stone's death as being due to a non-natural cause or a non-natural disease process?
Well, I with Mr. Stone, I was unable to make a clear decision when I reviewed the case on the balance of probabilities whether it was COVID-19 or another cause. So I did hypothesise that there could be an unnatural cause, a traumatic cause related to the fall. But I'm comfortable, as I indicated earlier, accepting the opinion of my colleagues who believe that the patient's death was most likely related to COVID-19 infection.
I see. Thank you. Just one other follow-up question. If the possibility of traumatic intracranial pathology arises, does that suggest that there was an indication for transfer to hospital, either for further investigation or for management?
Potentially, although I did note following the fall there was documentation of head injury observations for a period of 4 hours, which is usual practice.
Thank you. Professor Kotsimbos, same questions, first in relation to the ability to exclude or rule out the possibility of a non-natural cause of death of Mr. Stone?
It's very hard to exclude it completely, but I would say that, just looking at my notes here, he did have headache on the 19th. That wasn't an ongoing or an increasing problem. He did have mild temperatures and sore throat around the time of the fall, and some hypoxia, and that did seem to progress. So on the balance of probabilities, I went with a chest infection problem.
Thank you. And the same follow-up question, accepting it may be outside your scope of practice, did the consequences of that mechanical fall on the 22nd of April 2020 and the possibility of a traumatic brain injury give rise to an indication for transfer to hospital for either further investigation or management?
I think it was a real possibility, yes.
Thank you. Professor Curl, same questions for you, if I may. Firstly, whether the circumstances of that mechanical fall and the possibility of traumatic brain injury means that the possibility of a non-natural cause of death can't be excluded for Mr. Stone?
It can't be excluded, but he continued to have symptoms of respiratory illness, so one would therefore say on the balance of probabilities it was COVID infection that he did die from, rather than, in this case, an intracranial hemorrhage, which I guess is what we're thinking about with a hit to the head.
Thank you. And same follow-up question. Did Mr. Stone's presentation following the fall on the 22nd indicate transfer to hospital for management, for further investigation or management?
It could have been, but he wasn't on anticoagulants, so, and he was relatively young by 74. So the chance of an intracranial bleed is probably a little less than in an older person who might be on anticoagulants. He did have observations done following, I think for the 4 hours following the possible head injury. So clearly people did think of it, but it wasn't considered to be highly likely and therefore not a reason for transfer for a CT scan of the brain.
Thank you. That's all the questions that I had. I'll just check with the other legal representatives whether they have any questions for the expert conclave. Firstly, Ms. Clark, do you have any questions for any of the experts?
No, no questions, Your Honour.
Thank you. Mr. Palfrey, do you have any questions?
No questions, thanks, Your Honour.
Thank you. Ms. Davidson, do you have any questions for any of the experts?
No questions, thank you, Your Honour.
Thank you. Ms. Richardson, would it be convenient if I turn to you next and ask whether you have any questions?
Yes, I don't have any questions.
Thank you very much. Lastly, Mr. Fordham, any questions?
Yes, please. Professor French, can I ask you a couple of questions about drugs that may or may not have been available as at April, May of 2020? And I'm not suggesting anyone here giving evidence today has mentioned these, but I just want to run them past you. You mentioned, I think it's remdesivir.
Remdesivir, yep.
Yeah. My understanding is that only got some form of conditional approval in July of 2020, is that right?
Yes, it was being used off-label prior to that, but not regularly.
Another drug called It's tocilizumab.
Tocilizumab.
Thank you. That also wasn't available?
That was only used in the context of clinical trials at that time.
There was also a critical shortage of it at the time?
Yes.
There's been a lot of discussion about dexamethasone. I think you have all said that wasn't available at the time.
It wasn't in routine
Sorry.
use. It was available, but it wasn't in routine use for that purpose.
Yeah, exactly. And I apologise for that. It certainly was available, but not used. Is that correct?
That is correct.
And I don't think it was until sometime in July that there was a conditional recommendation in relation to dexamethasone.
Correct.
I'm just going to object, but it's more by way of clarification. The questioning moved from an answer not routinely used to not used, and perhaps clarification may be sought in that respect.
I'll do it.
Thank you.
Dexamethasone was used in relation to a number of respiratory conditions in the years leading up to the COVID outbreak. Is that right?
Yes, it can be.
In relation to COVID itself, it wasn't, whilst it could be used off-label, it wasn't routinely used until about mid-2020. Is this correct?
That is correct. It wasn't routinely used up until that point in time. It was, some centres were using it, but it wasn't common practice or widespread practice at the time.
And the question I put to you, I think, that drew the objection, amongst other things, was that there was a conditional recommendation from the COVID task force in about July of 2020. Is that right?
I believe that to be the case.
Professor Katsimbas, do you agree with that?
Yes, I do.
Professor Curl, are you still there? I've lost
I
you.
am. I seem to have disappeared from the screen. But
you're
I'm
back.
here. All right. Thank you.
No, you've just heard all that. Do you?
I heard all that. No, it's certainly not in my area of expertise, but I have no comments about my colleagues' answers.
Right. And where have you referred to the potential availability of dexamethasone in your report at 20 and 21, you'd now agree that that would not have been accurate in relation to this set of facts as at April 2020?
You're referring to my report?
Yes, I am.
And which paragraph? Sorry.
I was just looking at, for instance, page 21 under 4A, you're talking about hospital in the home at paragraph 156. You mentioned a number of things, including dexamethasone. It's about 2 lines from the bottom.
Yes, yeah, it would, yeah. Because that was actually used for asthma in, I think, treatment of asthma in one of the residents, possibly the last resident we talked about, Mrs. Bacon. I think she was going to receive dexamethasone.
But you're not suggesting that was a blanket treatment available for the treatment of COVID of this cohort, correct?
That's correct.
Now, I think you said you had some involvement in relation to Dorothy Henderson Lodge, Professor Cole.
Yes.
You're aware, aren't you, that there were, I think, some 16 cases?
Object. 17.
All right. 17.
Thank you.
12, I think, were transferred to hospital. Is that right?
I think that's correct, yes.
And of those 12, 6 unfortunately died.
No, I think 6 died in total.
That's right.
But they weren't transferred to hospital. A number of those were in Dorothy Henderson. They didn't go to hospital. That's my understanding.
According to Professor Gilbert, there were 4 who were not transferred and all 4 survived. Do you have any reason to question that?
Oh, no, if that's what she said, I'm sure that's correct. I understood that there were at least 2 deaths in Dorothy Henderson from people who did not transfer to hospital.
We'll sort that out one way or the other.
And just note this, I don't understand that that was an accurate reflection of the numbers. my understanding, and we're just finding the reference now, is that there were 6 deaths. 5 of those occurred in hospital.
I see.
That's my understanding, but we're just pulling up the reference.
The note I had was from Professor Gilbert's report, but we can sort that out one way or the other.
All right, very well.
Yes, I'm sorry. Had I realised I'd be questioned on this, I might have gone back to the original notes.
I'm just for my friend's benefit, Doctor, this is not a criticism of you. We're just trying to get to the bottom of something. What
Yeah,
I'm
no,
looking at,
that's
12 were
fine.
admitted to hospital, of whom 6 recovered and 6 died, including 1 who returned to Dorothy Henderson Lodge. That's a cut and paste. No,
Yeah, no, I do.
These are the right figures.
We'll have to. I just don't think a simple proposition could be put to the witness. This is the problem. Numbers are being put to the witness. I mean, she can be asked to assume things for the purpose of the question, but I'm looking at another part of the report. It just doesn't make it so clear. That's the problem. We'll need to obviously address that.
this won't take this evidence any further. We can read the report itself.
Yes.
All right, thank you.
Given the time.
Yeah, that's right. Yeah, that's right.
In relation to the either advanced care directives or advanced care plans, can let's deal with that subject for a moment. Do I understand your evidence this way, Professor Katsimbas? It's a difficult decision, a difficult discussion that has to be had. You need to say something that gets recorded.
Oh, sorry. Yes.
In order to properly evaluate the nature of the consent that was taken, you would actually need to have an accurate understanding of exactly what was said by the individuals in the meeting. Do you agree with that?
Do you agree with that?
The form itself is a tick box that is a summary, essentially.
Yes, and that's the difficulty for someone reading to try and gauge what's happened.
The notes themselves are always a summary of what's occurred. And so in order to either be critical or to endorse the consent exercise, if I can put it that way, I'll withdraw that, the planning exercise, you would need to have an accurate understanding of exactly what was said. Isn't that right?
Yes, but it can be said that if the advanced care plan has occurred outside of the COVID pandemic situation, it's unlikely to have included those factors.
And within the COVID pandemic situation, what you don't have is the full picture of exactly what I've just put to you. Do you agree with that?
That's true, but there were cases where advanced care plans were created with next of kin, where there was quite a lot of feeling that there was a lot of pressure in terms of how they were being presented and created. So I fully accept with any one, it's hard for me to say exactly. It's more a general statement.
Thank you. Do you agree with that, Professor French?
It's a general statement, yes.
Professor Curl?
Yes, as a general statement.
Yeah. And if I can put it this way, part of the pressure arises because you have a group of people facing a new phenomenon in the COVID outbreak in a sense of fear. Do you agree with that?
Yes, without putting a value judgment on it.
Professor French, do you agree with that?
Well, I accept that these are very challenging conversations, and in the context of a pandemic, that adds to the degree of challenge.
And do you accept that, Professor Curl?
Yes.
Now, Professor Curl, do I understand this correctly? In your report at about page 22 or 23, you go through certain things that may have been available had people been transferred to hospital. You remember being asked some questions about that? It's page 22 and 23.
Yes, I have that open.
Now, at the top of page 23, you refer to admission to an acute aged care ward. Do you see that?
Yes.
If you accept that the patients would have gone to a COVID ward at Nepean Hospital, that is not an acute aged care ward, is it?
It could well be, yes. Certainly in other hospitals, it would there would be geriatrician involvement, so it could be seen partly as an acute aged care ward.
You said partly. The proposition is this, isn't it? It's a COVID ward run by infectious diseases where you may get input from geriatricians. Is that what you're saying?
Yes, that's correct, but it's not just input. Often the geriatricians are actually providing a lot of the care, as certainly has happened at the hospital I work at.
You would have to ask for a consultation and bring them in. Isn't that right?
No, that's incorrect. In the case of the COVID ward at Hornsby Hospital, it was actually a geriatrician working in the ward as, if you like, the coordinating a medical specialist with input from infectious diseases and respiratory physicians. So that encompasses that team I was talking about earlier, and where necessary, a palliative care physician would also be involved.
That's at Hornsby Hospital. Are you aware of what the exact setup was at Nepean at the time?
Nepean have a very good aged care service, and I would imagine there would have been input into the COVID ward where it was requested. It may be, as you suggested earlier, a consultation model, but I can't comment on that. I don't know.
All right. Now I'm just going to continue with you for a moment in terms of, you spoke about the team when you gave your evidence that might be necessary to help care for patients such as those in Newmarch House. Professor Curl?
The team that would be caring for patients in hospital.
So yes, you're quite correct. You would expect involvement of infectious diseases. Do you agree with that?
Yes.
You would expect geriatricians.
Yes.
You would expect physiotherapy.
I'd expect a respiratory physician as well.
I haven't got to that yet, Doctor. If you could just perhaps bear with me.
Yep. Physiotherapy, yes.
You would expect the availability of things like occupational therapy?
In the management of day-to-day activities of daily living, possibly yes. Are we talking about management of COVID, or are we talking about day-to-day management of the residents?
I'm talking about the management of a geriatric patient with COVID.
Yes, in hospital.
In the hospital?
Yes, in the hospital. Then you would have occupational therapy and physiotherapy.
You would expect there be the ability to consult, if necessary, with ICU?
Yes.
You would expect the ability to have consultation with respiratory physicians?
Yes.
You would also expect, if it was necessary for any particular need, that, say, if there was an injury, someone might be able to perhaps consult with an orthopaedic surgeon.
If there was an orthopaedic injury, yes.
Just quickly, Professor Katsinamos, do you agree with that as a model to look after geriatric patients in a hospital?
Yes, as a model.
Professor French, do you have a view, or is this?
It's outside my area of expertise.
Thank you. Now, there was some discussion about the use of PRN medication in relation to anticipatory care. Do you recall those questions, Professor Katsinamos?
Yes.
It would be unacceptable, wouldn't it, if a patient required end-of-life pain relief and it was unable to be given because it was not chartered and there was a delay. Do you accept that?
Yes.
Do you agree with that, Professor Curl?
Yes.
Professor French?
Yes.
And so if it is that in order that to avoid unnecessary delay, anticipatory medications are chartered so they can be used if required, you'd agree that that's an acceptable approach, wouldn't you, Professor Katsinos?
I think yes, but I think also if there's any possibility that in writing up anticipatory medications, I may significantly influence expectations, then I need to factor that into it.
Yeah. And one way or the other, you would need some evidence available from some witness to say that the writing up of that recommendation somehow affected their thought process.
Yeah, I cannot say that for any specific situation. Again, it was a general comment.
Agree with that, Professor Cole?
Are we talking about a hospital environment here?
I'm just talking about the use of PRN medications.
In which environment?
I'm talking generally at the moment. I'll become more specific in a moment.
Okay, well, when you become specific, I'll answer that, because in a hospital situation, you would be able to write up those medications, hopefully, and have them administered fairly quickly. It may be different in a residential care situation because those medications need to be obtained from a pharmacy, and that could take time.
That was my next question. At Newmarch House, if you were going to have people being palliated or given comfort care in Newmarch House, you had to be in a position to give them those medications should they require them without delay. Do you agree with that, Professor Cole?
I don't think that's an excuse for writing up medications for every person when they become COVID positive. I think it's certainly a reason for writing up those end-of-life medications when it is clear the person is pursuing a palliative care course.
Professor French, do you have a view? I see you've put your mask back on. It's the case, isn't it, that Schedule 8 medications in New South Wales have to be delivered by a registered nurse or, I think, an endorsed enrolled nurse, Professor Curl?
Yes, that's my understanding.
And are you familiar with those concepts in the Victorian setting, Professor Katsinos? Yeah. And it's the case, isn't it, Professor Curl, that you would expect a registered nurse as part of their training and experience to know when it is they ought to consider administering PRN medication?
It depends if they've had training in that particular area, yes.
Do you agree with that, Professor?
Yes, I would also add it's often done under the direction of the supervising medical person in charge.
It's the case, isn't it, that if the registered nurse is unsure about what he or she should do, what they ought to do is call whoever is available, if they're not physically present, on call to discuss it with them.
I would have thought so.
And what you would expect is a system, say at Newmarch House, where there was after-hours ability to call someone from VAX, for instance, if you needed advice or assistance.
Yes. It's not clear to me whether you're looking at me or Professor Curl.
Well, I'm sort of looking at everybody, but okay. I'll try and
I
be
would
more...
answer yes as well to that.
Thank you. Professor French?
I agree with my colleagues.
Now, high flow oxygen is delivered, I think you said, Professor Katsinos, from hard plumbed gas supply.
Yes.
Does it go through a particular device in order to be delivered at high flow?
It does.
Do you know whether or not, as at April 2020, Nepean Hospital's COVID ward had those devices?
No, I don't believe they did.
And so if it were that something like high flow oxygen was to be delivered, it would have to be done perhaps in ICU.
Or a hospital ward with respiratory oversight.
Professor Curl, do you have anything to add to that?
No.
Professor French?
At the time, high flow oxygen was delivered in wards and in the intensive care unit at the institutions where I work. But it is dependent on the availability of machine, the appropriate device.
Now, Professor Katsinamos, you were discussing the use of rooms, and I think you said something along the lines of the use of single rooms was preferred or ideal or something. It was a long while ago.
Yes, in the setting of an infection control approach, it makes a lot of sense to have single rooms for a whole lot of reasons.
Just perhaps in short form, given the time. What are some of those reasons?
Well, the patient is in that room. Everything that the patient touches is in that room. There's a clear distinction between inside that room and outside that room, and the need for limiting visitation. And if there is care provided, the appropriate PPE that is often outside the room that is appropriately donned and removed going in and out of the room.
Professor Curl, you're aware, aren't you, that the residents of Newmarch House were all in single rooms?
Yes.
Were you aware of that fact, Professor Katsimbos?
I knew they were, your point was they were predominantly single rooms or all single rooms?
All.
Yeah. I wasn't aware they were all single rooms, but I'm happy to take that.
That assists in, amongst other things, infection control, does it not, Professor Katsimbos?
It does, but infection control is more than just having the substrate of a single room. It's also how the room is used, how PPE is used, what the ventilation aspects of that room are. There's a lot of operational aspects on top, but it's a good start.
Okay, well, let's add a couple of things. Individual split system air conditioning to bring air in and out of the room, that would be helpful, would it not, Professor Katsimbos?
It would be helpful.
You agree with that, Professor Curl?
Yes, it's beyond my area of expertise, but yes, I'm happy to agree to that because clearly it means one air source for each single room.
Professor French?
It may improve things. It depends upon the degree of air exchange. Certainly in a hospital setting, the general wards have 6 complete air exchanges an hour. It's 12 air exchanges an hour in a negative pressure isolation room and up to 20 air exchanges an hour in an operating room environment. So and the frequency of air exchange is a very important factor as well.
Yeah.
Could I also add, it also depends on where the air is coming in from and where it's going out.
Yep.
And whether it's HEPA filtered as well.
In a large hospital, aside from the negative pressure rooms, the air is a reticulated system usually for the whole hospital, isn't it?
Yes, but it's all HEPA filtered. Yeah.
Now, I'll ask this to Professor Katsimbos, given the title of the document I'm about to look at. Are you aware of the Australasian Society for Infectious Diseases?
Yes.
What is it?
It's a society of infectious disease specialists.
And are you aware that they were putting out interim guidelines for the clinical management of COVID-19 in adults and possibly other cohorts, but in early 2020?
Yes, they were, as was the ICU specialists and respiratory specialists.
And you would expect an infectious diseases physician, amongst others, to take account of those guidelines?
Yes.
Are you aware that the society, as at March of 2020, were advocating contact and droplet precautions?
Yes.
There was the risk of aerosol spread.
Yes.
Is it the case that the use of oxygen, high flow oxygen in particular, runs the risk of aerosol spread?
There is a risk. It's much smaller than we initially thought. In fact, subsequent studies have shown that, and indeed my colleague has been part of those studies. My colleague next to me.
I'm guessing that's Professor French.
Professor
Yes.
French.
And that the recommendation, at least on the part of the society as at March of 2020, was avoiding, where possible, aerosol generating procedures.
And that was our approach. And I think there's a couple of operative words there: guidelines, avoiding where possible, and then the other side of it, the benefit of high flow oxygen in a situation where it's needed, and then risk mitigating it as much as possible in the setting of a single room and the appropriate PPE.
Were you aware whether or not it was suggested there should be things like repeated chest radiology as at March of 2020, Professor Katsinbos?
Not as a specific recommendation, not specifically, but it's something we would do as an initial assessment, and then as the clinical situation changed, we would also do that, weighing it up with the exposure risk of moving people and bringing people in to do chest X-rays.
And things like deterioration or intubation might be a reason to do.
Yes, exactly.
Supplemental oxygen was certainly recommended at that time.
When required.
Yeah. I think that can run anything from 0.5 of a litre up to, it can go quite high, but usual figures are around, 3, 5, 6 litres a minute.
So through low flow nasal prongs, yes, and then obviously with masks a little bit higher, and with high flow a little bit higher, and then in closed systems even higher.
Do you have anything to add to that, Professor French?
No, I agree.
Professor Curl? No, you're shaking your head. I just need you to say something.
No, sorry.
All right. Now, there's been also, as at March of 2020, the society was not recommending the use of non-invasive ventilation. Do you recollect that?
Yes.
And was that because it was associated with a high failure rate?
It was a combination of things. Most of the people had, most of the requirement was for oxygen rather than a ventilatory requirement, which non-invasive ventilation was more likely to be useful for.
Professor French, do you have a...
Yeah, and there was also concern about it being an aerosol generating procedure as well.
Professor Curl, do you have any comment on that?
No.
No. Because COVID is it has a respiratory impact, if I can put it that way, the ability to keep the lungs functioning is particularly important. Do you agree with that, Professor French?
What's important is to try and maintain adequate oxygenation and ventilation of the patient. COVID, unfortunately, when people are severely ill, affects the function of the lung quite dramatically.
One of the things you need to do is preserve lung function.
Well, you try to preserve lung function as best you can.
Do you agree with that, Professor Katsin?
Yes.
Professor Cole?
Yes.
Do I understand this correctly? There's been a bit of a debate over the last few years about the use of fluids, and in particular the debate between the impact as seen by the renal physicians and the respiratory physicians. Is that correct?
I don't know. Well, it depends on the specific situation. Fluid is always important, and like everything, the big problem is when there's not enough and where there's too much. So it's about having the right amount in the right space for the right reason.
And are you aware that, at least as at March of 2020, the Society was advocating the use of restricted fluid strategies?
Which society, sorry?
The one that we referred to a moment ago.
Infectious diseases.
Yeah.
So in the
Object. The whole point, I've got it in front of me, should be read, please.
It will be.
So the whole...
Just a moment, sorry, Professor. Sorry, Mr. Buchan.
An assumption was put to the witness that doesn't fully state what the guideline was. And rather than doing it in a piecemeal way, the guideline should be put in its entirety in my submission.
Right, Mr. Fordham.
I'm entitled to put a general proposition and then put the specific. I asked whether or not he's aware of something, and then I have to put the specific guideline.
Yes, all right, very well, go on.
Yes.
Are you aware that as at March of 2020, the Society was, in relation to general management, advocating the use of restrictive fluid strategies?
So the context is very important here. So the context of severe COVID pneumonia, the concern was in a very inflamed lung, more fluid in a leaky lung will make the lung wetter and further impair oxygenation. The other side of it is we need enough fluid to make sure we have an adequate circulation so that the other vital organs, the brain, the kidney and so on, are properly perfused. So it's the context is important. Now, sometimes we have a real tension. We're trying to prevent prevent excessive fluid in the lungs because that will limit oxygenation, and at the same time have adequate circulatory fluid so the proper organs are perfused.
Before I come back to the whole recommendation, Professor Curl, do you have anything to add to that?
No.
Professor French?
I acknowledge that at the time there was a restrictive fluid recommendation.
And was that from other bodies as well?
The practice at the time was for a restrictive fluid recommendation for treating people with severe COVID infections.
So that was a practice.
I'm waiting for your next question.
So the severe COVID situation is quite important.
Under general management, and I'll read it all to you as requested, use restrictive fluid strategies, 1 to 2 litres of IV fluid per day, only if no oral intake or clinically dehydrated. Correct? You'd agree with that as a proposition?
In severe COVID, yes.
Now, just to go back a step, were you at the time, we're talking March, April, May 2020, Professor French, adopting the restricted fluid strategy?
I'm routinely dry, shall we say, from an intensive care perspective. And we've been using a restrictive fluid strategy in severe lung infection for some time, whereby by restrictive, we mean the administration of around, depending for an average adult, around 70 kilos, 2 litres of fluid a day, but not giving additional supplemental fluid.
Is the expression run them dry, is that a expression you've heard?
Well, there's the dry versus wet debate. But traditionally, our Australian practice is to run them drier than other jurisdictions overseas. But running dry is more, it's not entirely accurate because the patients aren't dehydrated, they're just not overhydrated.
It's a balance, is that what you're saying?
But it's important to maintain euvolemia, as in the patient has a normal volume. What we're saying is it's also important not to give excessive fluid volumes. And traditionally, when patients were unwell, there was this phenomenon called third space losses, and people would give lots of extra fluid. That's now being challenged, and that's what a restrictive lung strategy involves. A restrictive fluid strategy involves not giving the excessive amount of fluid that we used to give, rather than actually deliberately running patients dry, so to speak.
Professor Curl, anything to add to that?
No.
Professor Kotsimbos? No. Simbos, sorry.
That's okay.
Been a long week. Now, just in relation to that analysis about fluids, does the presence or absence of underlying heart condition come into the question of how you analyse that?
Completely.
And does the presence or absence of blood pressure medication come into the question of how you analyse how much fluid you give?
Completely, because in both situations you can go under or over, and you have to individualise it, and particularly for the situation that the lungs in and the rest of the body.
Thank you. And Professor French, do you have anything to add to that?
No, it's a titration, but just because someone is on blood pressure medication or someone does have heart failure does not necessarily mean that you should not give them maintenance fluid.
Now, Professor Curl, the residents at Newmarch House, by definition, a geriatric cohort. Agree with that? There are two main reasons people end up in residential aged care. One is cognitive decline and one is physical decline, or perhaps a combination of both. Is that fair?
Yes, that's a fair statement.
Normally in an aged care facility in the area where you work, in times not involving a pandemic, the numbers of registered nurses are extremely low on a given shift.
There's usually, it depends on the organisation. There's usually two for up to 60 residents and one overnight.
Are you aware from reading the records that after the 24th of April, there was a larger number of registered nurses being sourced and put into Newmarch House?
Yes, I believe St Vincent's nurses and others were involved.
Yeah. Providing care above and beyond what is ordinarily available in a residential aged facility?
In terms of
medical care?
Nursing care or personal care?
No, nursing care. Now, do you agree, Professor Curl, that it was imperative that there was geriatric oversight and management of these patients with residents within Newmarch House during April, May of 2020?
For those that had COVID, absolutely.
And indeed, those who didn't have COVID also required their ordinary care to be managed. Do you agree with that?
Yes, but that doesn't necessarily need a geriatrician. Usually the general practitioner would provide oversight of care.
You made the comment before about general practitioners. You are aware that general practitioners were sourced and placed into Newmarch House by the Commonwealth?
No, I wasn't. Was that clearly documented in the notes?
I'm unaware, but if you accept from me that general practitioners were sourced and placed into Newmarch House, that provides an additional layer of medical cover, does it not?
Yes, I wasn't aware of that. I didn't see their notes in the notes that I was provided for those 19 residents. There were particularly notes from Dr. Kakat, and there was information from a number of other GPs who were required to write the death certificates, but I wasn't aware that they were actually in Newmarch House.
Now, just to split all that up for you, and I'll come back to the others in a moment. You're aware that initially the GPs who were the regular GPs of these residents were not attending Newmarch House once the outbreak had been declared?
Yes. There were issues with them attending, yes.
Are you aware that at least some of those GPs were included on case conferences with VACs from time to time once those case conferences started?
That's very good to hear.
That's something you would encourage?
Very much so.
And I think you've stated that you weren't aware that there were actual medical practitioners sourced, aside from here, and VACs, sourced and placed into Newmarch House by the Commonwealth.
No, I wasn't.
That moves Newmarch House a little bit further away from an ordinary residential aged care facility.
Object.
To what?
No timeline's been provided. It's just been stated as a general proposition. The GPs were installed in the manner that's been described. Those questions weren't objectionable. But when you move to the next step of talking about the effect it had on Newmarch's capacity, then there really needs to be that specificity provided as to timeline, excuse me. The 29th of April, I understand, was the start date.
All right. Forum?
The difficulty was that Professor Curl didn't know they were there, so anyway. after the 29th of April, if you accept from me and indeed counsel assisting that the general practitioners were placed and other medical practitioners by the Commonwealth into the facility. Accept that?
I'll take your word for it.
That's moving it further away from a residential aged care facility and a bit closer to a hospital, isn't it?
I don't know many hospitals that have GPs in them, and I'm not sure, were these full-time? Were they acting like senior registrars? Were they visiting? I just don't have any notes of their involvement in the patients that we were given information for. And so I am rather flummoxed that they were there. Perhaps that they started at the end of April and our last information was, well, the last patient died on the 19th. So that was 3 weeks that they were there. I'm just looking at my more detailed notes to see whether there's any mention of other doctors, but it's mainly Dr. Kakat, Dr. Sharma, Dr. Kathirasan that were mentioned. It would be useful to know what sort of time they were in the care facility for. Were they dealing with medications?
Perhaps I'll deal with it slightly differently. Professor Curl, you'd be aware, wouldn't you, that rural hospitals all over the country are staffed by general practitioners on a daily basis?
Quite a few of them are, yes.
Professor Katsimbas, you raised the issue of communication. Do you remember that?
Yes, several times.
And I think you made mention of the fact that there was difficulty for HIF, and I'll ask you to include VAX, contacting, for a variety of reasons, people within Newmarch House.
That's something I gleaned from the notes. There was a lot of there were a lot of entries alluding to that.
Do you agree that those entries were primarily in the first, perhaps 7 to 10 days?
Well, it's hard for me to remember that. It's hard for me to remember that.
Are you aware that up until the 24th of April, that VAX had access to the computerised notes that you have access to for your brief?
Am I aware of that? I'm not sure. I just, the VAX involvement wasn't, from the notes, wasn't huge. I think my general take of the notes was that as the time went on, entries became less and less. It's hard for me to be more specific without the exact notes in front of me.
In the absence of being able to talk to someone, do you accept that being able to read the electronic records remotely is better than no communication at all?
Better than no communication, but I think it's all about the communication being appropriate for what's happening at the time.
And Professor Curl, can I ask you a question about the model where things are done virtually? I think you said that the people arriving virtually would be getting their information from someone at the facility, or words to that effect?
That's often the way it would work, yes.
So the person, say, from something like VAX, is able to talk to a registered nurse or perhaps a doctor who is present in a facility and take information from them. Whilst not ideal, at least they have a nursing person or perhaps a medically trained person that they can ask questions about the patient who is there with the patient. Do you agree with that?
Yes, certainly if that's the situation, that should work.
And is that something that you've done from time to time yourself?
In terms of dealing with a residential care, a resident in residential care and speaking with the GP who is there with them, Yes.
Or I suppose it hasn't happened in your case, but a registered nurse as well.
Yes, that would happen as well.
Your Honour, I'm just rising to my feet now, and I'm sorry. I apologise to my learned friend for interrupting his examination. The Victorian experts need to be on a flight at 6 o'clock. And obviously they're busy practitioners, and there'll be consequences if they miss their flight, as I understand it.
I will do this quickly. I have heard what my friend said. I obviously have certain duties to my client.
Of course.
I was going to suggest that if Mr Fordham still has a significant area to cover, rather than him brushing through it, we make arrangements for some sort of audio-visual link in terms of the taking of the final part of the evidence. I might have some questions of re-examination as well, you see.
Yes, that's what I was going to indicate, that Mr Fordham firstly should not feel constrained at all in asking any questions that he wishes to ask, and secondly that it may be appropriate, subject to the convenience, of course, of the experts, for the balance of the remainder of the evidence to be done by way of audio-visual link if the time and schedule allows with some modification. But Mr Fordham, as I said, you should not feel constrained at all in relation to any questions you wish to ask.
All right, well, I don't have much to go, so perhaps we'll see how we go, and I apologise to all of you. There was some discussion about Ms Billinghurst and the oxygen cylinder. Do you recall that? I think you perhaps gave evidence about it, Professor Katsimbos.
I think several of us did, but I did also.
Are you aware that it's a bit hard to work out on the notes, but it appears that it was realised at about 4:15, and by 4:29, the SATs were back up above 90%?
When it was corrected?
Yes. And in order to know whether...
I can't remember the times, but I remember the trajectory.
And in order to know whether or not that had any particular influence, you would have to know for how long the oxygen SATs were low.
And what her thresholds to the oxygen being that low for were, and so on. But yes.
So it's unfortunate, but you can't say what effect, if any, it had.
Yes, in some ways, I think there are two things. They are the immediate effects, but from the notes, there didn't seem to be an immediate effect. But there is an ongoing effect in terms of the psychology of what was going on and what it was a marker of.
Now, Professor French, do you have anything to add to that?
No.
Professor Curl?
No.
Now, am I correct that this first wave of COVID that came out of Wuhan, the incubation period was said to be 14 days?
There was a range.
Up to 14 days?
Up to 14 days.
You agree with that, Professor French?
Yes, up to 14 days, but I think the majority were in the 7 to 10 day range.
Professor Curl?
Yes.
And in terms of when you're referring to people being infected early or late, the infection could be, depending on when the last negative test was, just exclude the testing for a minute, up to 14 days beforehand.
Could be,
yeah.
But unlikely to be in all 19 patients. So you would have to take a probabilistic approach. If most of them were between 5 to 7 days, let's say, then that's the way you should think about the problem.
And if most of them were between 7 and 10, you'd have to think about the problem that way.
But most of them were between 5 to 7, I think, is
my
recollection.
And just to complete that line of logic, if most of them were 14, you'd have to think about it that way.
Yes, I think it's about applying the right probabilities to the model.
And one of the problems is that you can be asymptomatic for a period which doesn't give rise to anything you would see in the notes. Do you agree with that?
That's the problem. Yes, exactly.
Professor Curl, do you agree with that?
Yes.
Professor French? Anything else? Oh, yeah. And the other proposition is you can be incubating and test negative.
You can be, but depends on your viral load and how the swab was taken.
Yeah, and to flip that, the other side of that equation is that you might be positive, but you get a false negative because the swab is insufficient due to a number of reasons, skill of the taker, or in this case, more likely, the cooperation or otherwise of the resident.
Yes, and sometimes there are inhibitors in what's been taken, so it doesn't work. Sometimes the infection being here up in the upper airway first, there's more time that has passed, so that becomes lower viral load, and there's a higher viral load deeper in the body. So there's several considerations there.
I'll just be one moment. I think we're done. Where are they? Oh, there was some questioning about Ms. Rendoff. Professor Kerr, were you aware that there's a note from the 22nd of April at 5:31 where there was a discussion not for resuscitation, not for intubation or ventilation, comfort measures?
On, sorry, which days?
22nd, it's not an advanced care plan, but a discussion within the notes.
Okay, yeah, no, I don't have it in my notes, but I'll take your word for it. Who was the discussion with?
I'd have to go back to the notes to check it. I'm looking at a note and I apologise, but given the time, I might just have to do it this way. I think you said there was an advanced care plan. I'm not sure there was, is my point.
All right. I've got an advanced care plan requesting all interventions other than resuscitation. So that's obviously what I gleaned from the notes, but I could be wrong.
Yes. All right. Thank you. I have nothing further.
Thank you. Mr. Bew.
I'll be very brief, given the time constraints. Professor French, you referred to air conditioning systems being HEPA filtered. What does that mean?
It's a high efficiency particulate filter, so it filters out very small particles, so indeed droplets and aerosols that contain COVID-19. So they are not part of standard air conditioning systems. They tend to be obviously in hospital systems.
These are used in a standard way throughout hospital wards, is that right? Secondly, you asked some questions about a document published by the Australian Society for Infectious Diseases, ACID, or ACID. We've just been provided with the document. Can I just draw your attention to one aspect? There's a section that says at the beginning, assessment for hospital admission. And the first point says this: where possible, patients with a provisional or confirmed COVID-19 diagnosis should be managed out of hospital, example at a home or in a step-down facility, as per local jurisdiction policies. But then it goes on to say this: consider admission if any of, hemodynamically unstable, hypoxemia, in brackets, oxygen saturation on room air below 94%, reduced platelet count, comorbidities, or unsuitable home environment. Now, looking at it, this is a guideline only, of course, but looking at that particular guideline, how would it operate in the context of what was happening at Newmarch House?
I think all those things hold true, I think.
You're talking about that list of circumstances.
Hypoxia, significant problems with circulation, significant problems with platelets. That relates to the clotting thing being potentially a problem. And then
comorbidities.
And the comorbidities and so on. But
unsuitable home environment.
But it's a guideline and it has to be weighed up against everything else.
Correct. Professors, any further comment on that? And lastly, you were taken to the issue of restrictive fluid strategies. Professor French made the comment during the evidence that there's still fluid maintenance. Evidence was given earlier about problems involving lack of fluid delivery, and then the advantages at a hospital in terms of the capacity to provide fluids. Professor Curl made specific reference to subcutaneous fluid delivery. Does what was put to you about restrictive fluid strategies cut against the earlier evidence that you gave about fluids in any respect?
No. Restrictively, it's a specific treatment strategy for critically ill persons with COVID-19 that are hospitalised, and it does not negate the need to give maintenance fluid.
Professor Katzimbos?
Exactly. It's about severe inflammation in the lung where you're trying to get every bit of extra oxygenation. A lot of the situations we were talking about were related to much earlier time events, and an adequate circulation there is perhaps the higher priority.
Professor Curl?
Yeah, I agree with the comments of my colleagues.
And lastly, the guideline that was read to you used restrictive fluid strategies 1 to 2 litres of IV fluid per day. It seems to be a reference to a situation where intravenous fluids are being given. Is that correct? That's only going to happen in a hospital, isn't it?
Yes, and often in someone who's not able to take care of themselves, and so in a very
I object to that question. There's evidence in this.
impaired position in an ICU.
Sorry, Professor, just one moment.
I object to that. The factual proposition on which that question is based is not correct.
Let me just rephrase that. IV fluids, that's likely to be a circumstance which is being addressed in a hospital. Is that right? Yes. That's a re-examination. Thank you. And I thank the experts for their time.
I was going to say, sorry, Professor Katzimbos, I think you were cut off while the objection was raised. Had you finished your answer?
I think I did. Please tell me if I didn't.
All right, very well, thank you. All right, thank you, Mr. Buchan. Professor Curl, Professor Katzimbos, Professor French, thank you very much for giving evidence throughout the course of today. We all understand that your collective time is valuable, so thank you very much for sharing that with us, together with your expertise and knowledge. You're now all excused, and Professor Curl, you're welcome to end the remote connection with the court.
Thank you, Your Honour.
Thank you.
And I'll just ask that the experts can leave the witness box.
Yes, of course.
They've got a car waiting so that they can get to the airport. Thank you.
Thank you. All right, just while that's occurring, I just wanted to flag one matter. I know it's late in the day, but I wanted to flag it now so that we don't run into any delays for the start of the evidence tomorrow, and that concerns the question of submissions following the evidence in the inquest. I understand that some discussion has been occurring amongst counsel and the legal representatives regarding the question of submissions. I'm content to let those discussions unfold. I merely flagged the issue at this point to indicate that in due course a timetable will be fixed, subject to the availability of all the legal representatives, of course, and don't need to raise it any further at this stage other than to just simply flag it, and probably that timetable will be set once the evidence concludes or once we approach that point.
Thank you, Your Honour. We'll continue to speak to the other parties about this issue and put a proposal to Your Honour about an appropriate timetable.
All right, very well.
Thank you very much.
All right, thank you again to the court staff for sitting late today. I'll adjourn until 10 o'clock tomorrow morning.